So we are recording.
Okay. Well, good afternoon and welcome. My name is Kathleen Borain and I serve as the Maryland Insurance Commissioner. I would like to thank you for joining us today for our second listening session for 2021. Today, we will hear from invited panelists, interested stakeholders, and members of the public regarding the role that insurance can play in addressing inequities in healthcare access and outcomes. Throughout 2021, the Maryland Insurance Administration, joined by other state agencies, has been holding a series of listening sessions to help us more fully understand the experience of specific communities relating to certain kinds of insurance. These listening sessions are critical to our fact-finding, particularly in a time when we haven't been able to be out and about as much as we usually are, although that is changing. But these listening sessions will continue nonetheless, and they will assist us to fulfill our statutory mission to serve Marylanders, both in our enforcement of Maryland's insurance laws and in our development of tools, guides, and programs for consumers. You will find a link to today's agenda in the Zoom chat box. So let me start by introducing the MIA staff that's with us today. We have Joy Hatchett, who is the Associate Commissioner for Consumer Education and Advocacy, David Cooney, the Associate Commissioner for Life and Health, Mary Quay, who is the Chief of Life and Health Complaints, Terry Smith, the Assistant Chief Investigator for Life and Health, Corey Boone, my Chief of Staff, Craig I, Director of Communications, and Victoria Laird, who is our Communications Specialist. If you registered to speak in advance of this listening session, we will call on you after our invited panelists make their presentations. We are very eager to hear your thoughts and your experiences. And to the extent that time and technology allow, we will open the discussion to non-registered speakers at the end of the session. So if you wish to speak, please just let us know by using the chat function found at the bottom of your screen. We want to hear from everybody, and hopefully time will permit. The other thing from a housekeeping standpoint is that I would ask you to keep yourself on mute unless you're speaking, because that will really improve the sound quality throughout the session. With that, let me also introduce my fellow state servants. So from the Health Benefit Exchange, we are very, very lucky to have Michelle Eberly, who is the Executive Director. And Michelle, let me just give you a second to talk a little bit about, for those people, if there is a person who's unaware of the Exchange and the Connector, if you could talk a little bit about what the Exchange and the Connector do.
Well, thank you so much, Commissioner Borain, and I'm just delighted to be here. At Maryland Health Benefit Exchange, we believe access to quality health insurance is as fundamental to Marylanders to achieve and maintain their best health. And we do acknowledge that some Marylanders face unnecessary barriers to understanding, enrolling in, and using health insurance, which contributes to disparities in health outcomes. We are committed at the Exchange to addressing disparities by identifying inequities built into the systems that intersect with our work and our populations, creating more spaces for diverse voices to inform our work, and meaningfully engaging with communities that we serve, and allocating resources to extend efforts in communities and among populations facing greatest barriers. We do offer affordable health insurance, and we're really happy to announce that under some recent federal changes, it's even become more affordable. So in fact, 9 out of 10 folks that come through Maryland Health Connection can find free plans, can find very affordable plans as low as $1 a month. So we really encourage people to come look at options. In terms of our communications that we offer and our assistance that we offer, we do have a call center that is always staffed with bilingual staff. We have access to over 200 languages that are available. We have in-person culturally specific assistance through our local health departments, our licensed producers, and our navigators. And our website, marylandhealthconnection.gov, and our mobile app are both user-friendly and available in Spanish and also other languages as well. So we do know during this time of COVID, when everyone has been very worried about their health, we have been able to make sure that all of our health plans cover testing for free, the vaccination and medical treatment as well. And having healthcare, especially during this time of pandemic, allows families to worry less about their health and stay focused more on their families. Getting vaccinated, which doesn't cost anything, allows families to be safe and really ensures the economic viability for families with creating more jobs and allowing more jobs to reopen. So we are here because we are very vested and want to learn more from those that are on this call about their experiences with health equity and or inequity. We've come a long way since the introduction of the Affordable Care Act, but we still have a long way to go. And we're most grateful to Commissioner Borrain and the MIA for this listening session that we are able to have today so we can learn more from you. Thanks.
Thank you very, very much, Michelle. The MIA values its partnership, with the exchange and, the information that you provide that then allows us to interface, with our licensees and working to make sure some of the things that you've just talked about in terms of coverage, are lived out both with respect to products that are on the exchange and products off the exchange. It's a very, very valuable relationship, and we all have to work together, which brings me to Dr. Martin. If Dr. Martin is the Deputy Director of the Office of Minority Health and Health Disparities within the Maryland Department of Health. And I know that your director, Dr. Brathwaite, will also be joining us at some point this afternoon, but perhaps Dr. Martin, you could introduce yourself and tell us all a little bit about what the Office of Minority Health and Health Disparities is focused on right now.
Sure, and thank you so much for having us on this at this event. Commissioner Borrain, thank you so much for your leadership, and we really appreciate all the work that you and your office does. So the Office of Minority Health and Health Disparities, our mission is to address the social determinants of health and eliminate health disparities by leveraging the department's resources, providing health equity consultation, impacting external communications, guiding policy decisions, and influencing the strategic direction of the department on behalf of the Secretary of Health. Overall, our vision is to achieve health equity where all individuals and communities have the opportunity and access to achieve and maintain good health. And as you can imagine, the pandemic to COVID-19, participating with our local health department partners, as well as our community partners to reach underserved and vulnerable populations. To that end, we played a major role with the vaccine equity to Brigadier General Janine Burkhead to push vaccine distribution out into our community, whether through partnerships, community-based partnerships. Also worked with our community partners and actually engaged our mass communications campaign to respond to vaccine hesitancy. So we've been actually over the last year 24/7 COVID response. Some of the other things that the office does do is we fund a number of grantees. I think we're up to 17 now. Our MOTE program, the acronym that stands for Minority Outreach and Technical Assistance. And these are small community-based organizations to reach to populace. And they specialize in things such as diabetes management, chronic disease management. So we fund them to continue to do that work. Among other things, we provide funding for community health workers, many of whom are with our MOTA grantees and some with our local health departments. And so we continue to look to really move the dial on health disparities and promote health equity. So I'll pause right there and stop with those thoughts right there.
No, I thank you. I mean, your office is doing, just tremendous work across, so many and, different areas. And I know that there's been a huge focus on COVID, but I know that your work expands, extensively, beyond the circumstances of COVID. And I'm just so pleased that both you, Dr. Martin, and you, Michelle Epperly, agreed to be here today, because really together, we represent such the full spectrum, and we need to hear this information, because across all of our agencies, we have really, I think, the ability to take the information that we're going to hear today and do something with it and about it. COVID has shined a real spotlight on inequities, but it didn't create them. It may have created more stress that deepened them and expanded them. But if it did anything, it shined a light on things that already existed. And so I thought that it was very, very important here that as we began, we really stepped back for a moment and understood sort of the landscape. And when we talk about, inequities in health and in outcome, what do we actually mean by that? And so with that, we have invited Dr. Kim Dobson-Sidner from Morgan State University and Dr. Stephen B. Thomas from the University of Maryland, Maryland Center of Health Equity, to share with us today their thoughts, their ideas, their knowledge, their wisdom on this topic. So let me introduce both of you. And I will start with Dr. Sidner, who's the Dean of the School of Community Health and Policy at Morgan State, and ask Dr. Sidner to just give us a little bit of background.
Thank you so much for having me. I appreciate it. When I got an invitation to the Maryland Insurance Administration, I was like, what can I do for them? And I'm happy to know I was not derelict in any of my insurance status or anything. So glad to be on this end of correctness as it comes to the administration. So again, thank you so much. I'm the Dean of the School of Community Health and Policy. Want to talk to you briefly about health inequity, root cause, and implications. Next slide, please. So we frequently, and Dr. Martin just mentions social determinants of health. It has now become sort of like the buzz byword. And I thought it was critical to table set to make sure people understood what SDOH, as the acronym is often provided, really means and represent. And it's nothing that complicated, but it is critically important. So those social determinants of health are those things about where people live, learn, work, and play. And so you see I have some nice cute little graphics to represent each one of those domains. There are a wide range of health and quality of life risk and outcomes that are affiliated with these. And there's a deep, deep empirical basis for talking about these social determinants of health. A lot of research that backs up why they're relevant and important to chronic diseases and a whole number of issues that we are concerned about. I gave you a reference for the CDC definition. It provides a very nice, sort of easy to read access to that information if you like. Next slide, please. Unfortunately, where all of us live, work, learn, and play don't look the same. They certainly aren't as pristine and sort of cartoonish as the prior graphic seems to suggest. There really are places where people live, work, learn, and play that are not conducive to individuals' well-being. And I think you can just tell from the photographs. I don't even think I have to say to you in words, the picture says, what is health like in areas or in these spaces where people, children, families, communities operate. It's quite different from what we expect. And so here are these root causes that are critical. And unfortunately, they have an inequitable distribution. Next slide, please. So the link between these social determinants and health equity and inequities, we talk about them both ways. It's about unequal distribution of power, income, goods, and services. And this power is not randomly distributed, right? If we thought it was sort of, some people have it, some people don't, there's no pattern or rhyme or reason to it, it wouldn't matter. But this power inequity really influences these, when we talk about structural determinants, things not created by individuals, but by systems and conditions that produce daily life. And the insurance industry is certainly part of that structure. or system really critical to what we have moving forward. Sorry, that was, I thought I turned off my cell and now it's not. Gone. So next slide, please. So this inequity, unfortunately, is often based on race, ethnicity, and geographic location. And I probably think this does not come as a surprise to anyone, though it should. It really should not be the case. But I think it's been present with us so long that we take it as yeah, these things happen, but they don't have to happen. They really are a byproduct of systems and structures that create this sort of inequity, this disallocation, I will call it, of this power dynamic and these resources and opportunities. And they're tightly woven into the fabric and health of communities themselves. So when people talk about what individuals can do, there's certainly lots of things you can do individually. I would never say, eat well, exercise, do all those wonderful things you're supposed to do. But beyond your individual behavior, these collective environments really do have a critical influence. And I think that's the hard thing for some of us to wrap our head around, but it is really critical that we understand it. It is not fleeing from accountability at the individual level. It's these layers that we are creating at the individual community and the larger social structure that really have influence. Next slide, please. So I'm giving Kaiser Family Foundation. It does some great work in this space. And I hope you can see, if not widen on your screen, it's just a graphic to show these drivers of health inequity. And I've kind of highlighted in red 2 areas where I think the insurance administration clearly has a role to play in the health sector, but also in some other sectors, and I'll talk about those briefly. So the healthcare system itself, you can see that health coverage is a critical driver of inequity. Ms. Everly just talked about the health insurance exchange here in Maryland. I'm grateful because my son is in that exchange and is getting affordable health insurance because of that opportunity. But everyone is not as fortunate, and that lack of access does have some influence on health outcomes for individuals. We all know that being able to go to the doctor freely and comfortably has something to do with whether or not you can afford it. Having an emergency and you make a decision, well, maybe it's not so bad, I can stay home because I don't have health insurance, I'm not going to have this issue checked. That really has some both immediate and long-term consequences at both the individual and the community level. And from a public health perspective, it really is this collective power that happens. And this happens in not random ways, but again, the data shows clearly health insurance access is not equally distributed. The other places, obviously medical bills, you can have health insurance, but you may not be able to afford the copays depending on what health insurance model that you have. The cost of pharmaceuticals, all these things, again, are not randomly distributed influences. They happen among, and unfortunately, the poorest of the poor sometimes have the highest copays unless they're eligible for these government programs. The working poor, the middle class who can make just enough money not to be eligible for federal programs, but really not enough money to surmount these costs. These are major influences that that really do kind of determine what our health outcomes are, and again, unfortunately, are not equally distributed. So I just wanted to give you one kind of graphic way. You can see these other disparities outlined: food access, community safety, social context, education, physical environment, economic stability. They're all interwoven. And insurance is a huge economic factor. When I think about when I was younger, so I won't give my age away, before they had the insurance, auto insurance coverage and MAPE or MIF or whatever they used to call it. One of the things my husband and I used to always struggle with was like the auto insurance. Like, how much is auto insurance given where we live? And then how much is auto insurance someplace else? And there were decisions made about, can I afford this insurance or not this insurance? Can I afford a car if I can't afford the car insurance? Mobility has a lot to do with where you live, how you live, and where you can work. So you can see how these ripple effects are really critical. Next slide, please. I brought another example from Kaiser, just in terms of what Medicaid expansion has done as it relates to racial and ethnic disparities. Again, I always try to include a URL so you can go back and retrieve this information for yourself. But this basically shows the light blue is where the study, where expansion has had no impact, and the darker blue is where the expansion has had more impact positively on health disparities. So you can see it big time insurance coverage itself. It's got a nice, relatively bigger blue block next to it. In the health outcomes and quality of care, certainly the areas we're concerned about, major influence, and even in economic measures, you see this deep blue pervades the graphic. Where it doesn't have as strong an influence is around access to and use of care, which is a conversation we need to remember. You can have insurance, but accessing services is one step away, right? You can provide the insurance, but there's more to be done, needs to be done and monitored once you have insurance. So I think this is what the take-home message from this slide, that health insurance matters. It is a good thing. Healthcare expansion has been a good thing in terms of racial and ethnic disparities, but we have more to do. Next slide, please. So before I go to this one, there really was one more discussion. In preparing for today's session, I sort of Googled homeowners insurance and health outcomes and auto insurance just to make sure I was on solid ground, because I do think that's important. And I did find that your National Association of Insurance Commissioners held a summit where race and insurance was a topic of discussion, and found that indeed there are still remnants of redlining and these other discriminatory practices that undergird how insurance is rated and then I guess costed out. So where you get the factors and ways in which insurance folks get rated, zip code is critical. Well, zip code sounds like a very neutral thing, right? Okay, it's fair where you live, but because of redlining, which is a historic pattern and practice of having certain minority groups living in certain communities and not allowing them to live in certain others, and then having property values linked to that, well, you can see how the dominoes fall around these issues of homeowners insurance, auto insurance, how we determine those rates, the net effect on that. And then again, as we talked about, the social determinants of health, this sort of sequelae that we put in motion. So once you zone and identify people by their zip code and not by their race, it looks neutral on its surface, but it is not neutral in its implementation. So we need to do more than just say, well, we think we're being racially neutral because of these systemic issues, because place matters in health inequity. There's more that the insurance industry can and should do in examining these particular effects. So my general observations, takeaways for you all are that inequities do have a strong racial and spatial component. So when people say race no longer matters, but race and space have become so intertwined that it's important that you not forget the other. That equal allocation of resources, just giving access where inequity exists, does not resolve the problem. It may ameliorate it to some extent, but in general, it will not diminish the gap and the disparities will persist. That these standard practices often fail to address systemic issues. So making changes at the surface sometimes are insufficient to really get at root causes. And you have to look deeper. And if you're in the social determinants framework, you know that you have to look in places and spaces and have partners you may never have thought of before in getting this work done. And then the other takeaway is that we need to be transformative. So just sort of thinking in our boxes is not going to help inside, I think, our insurance administration. And it doesn't look like you are, so I'm not, but I'm just saying, think deeply about something that may be even disruptive. We don't like disruption, it's uncomfortable. We don't like things to change radically, but this may be a moment in time and a space where being disruptive and innovative for the greater good of community is really what's at the forefront. Because at the end of the day, insurance is about protecting us, right? We get it to put a safety net. All the pictures I went to find about insurance showed an umbrella over top of a person or a building or a thing. But the bottom line is it's supposed to create protection. And if we really are concerned about protection and that investment, then let's not be worried about our system. Let's be worried about our outcomes of that system. Next slide, please. And so to that end, at Morgan State, we have been fortunate to be the recipient of funding from the state of Maryland, $3 million. I'm keeping my fingers crossed. That's what they told me as of July 1 to launch our Center for Urban Health Equity. We will be joining University of Maryland College Park and Johns Hopkins in having this Health Equity Center. We will be very action-oriented research and practice, and health insurance policies and practices are part of those areas of interest for us. We're going to be community-driven, listening to, hearing from, and then more importantly, I think, for the Health Insurance Administration, for the Insurance Administration, is that we want to be collaborative, have a broad, diverse network of partners, because no one entity is going to get this work done. So we stand ready to be partnered with any organization, any individuals already on this line in this administration to move this work forward. But social determinants of health are real, they matter, inequities can be redressed, and we have work we can do. So thank you for the time and opportunity.
Well, thank you for that. I know it was brief, but it was also very thorough presentation. You obviously given us, and you really have helped set the context and the stage, and I appreciate that very much. I two things. Michelle, I'm going to ask you, if you don't mind, to talk just a little bit about some of the changes in subsidies, because I think one of the things that Dr. Sidner said that was very, very important is speaking to the working poor. So folks that may not quite make the qualification for certain types of assistance, but really can't necessarily afford coverage. And so I do have another question for Dr. Sidner, but Michelle, I didn't want to lose the opportunity for you to be able to just talk to people on this call about how the recent changes have impacted who is entitled to subsidies, because that really has opened up a bit.
I'd be happy to. So in Maryland, we've done a really good job of keeping our rates low with the reinsurance program. But what was really game changing is when the Biden administration came out with enhanced tax credits for at least a 2-year period of time, this year and next year. And the big game changer was there used to be a cap. If you made over 400% of the federal poverty level, you were no longer eligible for any tax credits. Now that barrier has been removed, and so anyone can be eligible for a tax credit as long as the cost of the health plan is not more than 8.25% of their income. So that really has significantly increased the amount of tax credits. And as I said earlier, we're finding a lot of health plans that are very, very affordable, and many that can be obtained for $1 a month. So we're telling everyone, come back in or call someone and look at it, because those very particular people, the working poor that work hard every single day but couldn't afford health insurance, we're now seeing it's very affordable within their reach.
No, thank you for that, because I didn't want to let this opportunity go for you to sort of publicize that even further. I mean, the exchange does a phenomenal job with their advertising, and the new commercials are phenomenal. But with this audience in particular, to sort of emphasize that if you were someone that thought, or someone that thought that they didn't previously qualify, they really need to go to the connector. They really need to go to the exchange and see what it is today. The other thing, Michelle and her staff brokered this, and the MIA has approved it, contract exceptions for our licensees to allow that deductible in certain circumstances. If someone has already been on an exchange policy and they're looking at a different policy because they're able to take advantage of subsidies, that one of the things that the exchange initiated, asked the carriers to do, carriers were willing to do, we were willing to give the contract exceptions for them to do it, was to carry over that cost sharing. So you don't have to be afraid necessarily. There are some obviously limitations on it, carrier to carrier, but if you're moving into a more generous product and in order to take advantage of the subsidies, you're not going to lose the credit for what you've already paid out as deductibles or co-pays. You'll carry that over with you. You won't have to start all over again. So not exactly our topic today, but I didn't want to lose the opportunity to make sure that people really knew that, because I think Dr. Sidner, you made that really important point of kind of people who are caught a bit in between. And hopefully what the Biden administration has done and what the connector is doing and making that, getting that word out there eases some of the burden for some of those folks. I don't know if, I think Dr. Thomas may have been running behind and may not be on the line. Is that still correct?
Yes, he's not on the line.
Okay. So Dr. Sidner, if you don't mind, I know we have a panel that's coming on in a few minutes that's going to talk a little bit more with respect to, you know, some of concrete ideas and some of the things that carriers are currently doing and have been doing. But I would be very interested in hearing if you have any thoughts of your own about if there are specific areas, specific things that we should be thinking about kind of along the whole spectrum of where insurance comes into play, you know, where payment mechanisms and kinds of coverage, where coverage kicks in and how it operates, that would help to address some of the issues that you have described to us today.
Wow, thank you. It's like I should have thought more.
That's
Couple things that come to mind. One has to do with technology. So one of the great divides in equity is technology. And so for the industry to think about the ways in which people have to access information. We're such a digital age now, we assume a lot of people, but unfortunately there are significant pockets of the state where technology may not be up to par, where internet access is limited. And I know you say use a phone call, but when systems are built for a digital interface and you transfer to phone call systems, I don't know how effective or efficient those are. So that will be one place to evaluate for yourselves. What is your level of use of technology? Is it equitable? Do you have a viable alternative? And how are you implementing that? So I think that's one simple one. The other one, as I was sort of doing the research around homeowner and auto insurance, is to whatever extent possible to have a conversation with the industry about what are the rating factors. How do you rate? What are the factors you decide to create insurance premiums? Whether or not they remain fair and appropriate and equitable in light of where we are in the industry, and having a really hard conversation probably about the bottom line on this. I know it's probably one of the most difficult places to have influence, but it's probably one of the most critical because the issue of place matters. And people can say, well, we can show you data where the numbers are higher and our cost, but insurance is about spreading risk. I mean, I think I took a little course in school where they talked to me about health insurance. It's about spreading risk. You expand the pool, you reduce risk. I know that's a simplified version of it, but having a serious conversation around what factors are allowed to be able to make decisions around premium, to whatever extent you have a role to play in that.
And is that a concern, doctor? Is that a concern, doctor, that you have about health premium, or
It's more about homeowners than auto insurance. I think less in health premiums. I think, again, my son is in the exchange, so I took a look at them. I think on that side, it's about the technology and the systems and the access and assuring simplicity in language and communication. I think that's the other piece. So as Everly talked about all the great things that are going on, make sure the platforms for communication are really widely accessible and appropriate and culturally appropriate and all those things. We use this language of being culturally appropriate a little vaguely sometimes, because you really do, it's like you need to understand your target audience, what's attracting them. And so looking at your communications mechanisms and make sure they really are targeted and appropriate and make sense. If you overload people with information, you get nothing, right? You just get indecision and frustration, and it's like too complicated. You made me do 3 things and read 4 pages, and therefore I don't really have the impetus to go do anything you ask me to do. I'm going to ignore all of it. So I think communication seems like a simple thing, but it's key. But no, the underwriting in terms of health insurance premiums, I don't know all the decisions made in that lovely algorithm, but I'm particularly sensitized to homeowner and auto insurance because it is a health issue. If you think about the dollars you have to spend on food, housing, all these critical things that really do matter, your child's education, those decisions you get to make. If the dollars are being absorbed in insurance that is mandatory in most cases, then what's left for the other necessary elements of your life? And so it seems like a minimum thing, but I'll go back to that conversation I had with my husband when we were early on. It really did matter. I mean, it literally mattered how much we had to pay. I think we may have moved so we could get, we said, we probably need to move so we can get into a better area to get cheaper insurance. Now that's should not be necessary, but it mattered. I mean, literally that's how deep it goes in terms of the cost of it all over time. And if you're, I mean, I just looked at some of the rating, they take your previous history into account of insurance. Why would you do that if somebody's made a move to get themselves situated to be in a less high risk profile, but you're going to take into account their prior history? These things may have utility for the insurance industry, but they certainly don't in the realm of health equity. So I think these are just off the cuff. This is not kind of my domain, but the other piece is just to encourage you all to work with folks outside the insurance industry. It really is working with other organizations who can talk about how people make use of your insurance to understand how insurance needs to be better structured. I hope that helps.
It helps very much, and I very much appreciate your insight and you know, the kinds of dots that you're connecting. Let me ask Dr. Martin or Ms. Eberly if you have any questions, and I'll open that up to the MIA staff as well.
No, I think Dr. Sidnor did an excellent job of articulating some of the barriers that contribute to social determinants of health, right? So one of the things, as I was listening to Dr. Sidnor discuss the issue, that really came to mind for me is simplifying this whole notion of health insurance coverage, okay? We spend a lot of time, particularly in the type of work that we do at the Office of Minority Health and Health Disparities, making sure whatever strategy we're trying to implement, whatever intervention we're trying to implement, there has to be a component of it where the communication is simplified, it is sensitive, it is competent. Also, that the communication really does communicate the message that we're trying to deliver, and it compensates for reading levels, those understanding insurance, because it can really get confusing. So often, I think folks wind up selecting insurance because they just have to do it. But they really haven't had the conversation about, what insurance is really right for me and my family at this time. So I think hospitals could play a role there, especially when somebody's coming to the emergency room without insurance. Perhaps identifying those folks and reaching out to them individually, and having those engagements one-on-one with them. So I think for me, I tend to key in more on the communication and understanding of the health insurance coverage, the health insurance system as a whole, and making sure that minority populations, particularly those where English is not their first language, they're understanding what this is about. And here it is, why they should get it. All right, because when you're insured, as Dr. Sidnor so aptly pointed out, expand the pool to minimize risk. All right, we want to get you in there. All right, we want to get you the coverage that you need, and let's see if we can find a product that actually works for you. So that's kind of my comments on that.
And I have this question for Dr. Snyder, and then also actually for other panelists throughout the day. One of the challenges that we face often is we know that there's a lot of folks that have signed up for health insurance, and they may be even getting free health insurance through Medicaid, but we're having a challenge getting individuals to engage in that health insurance or select a primary care physician. So that is something that we're trying to figure out. How can we better get that engagement? Because on the policy side, from the exchange standpoint, we're constantly looking at ways that we can help address different situations such as diabetes, for example, where now the test strips are pre-deductible, no cost to the consumer. We're working for 2022 to have insulin and the glucometers, again, in that same cost-effective strategy, so that people can utilize the medicines that they need to stay healthy. But we have to first get our consumers engaged in selecting a primary care physician and getting engaged in care. So any ideas from anyone throughout the course of this listening session, we'd be very appreciative of.
Right, so there's a whole issue of medical system mistrust, whole body of research around that. There's also an issue in the Medicaid system about which physicians take what insurance coverage. And those are things that's sometimes not often discussed, but they matter. Who takes Medicaid is sometimes frowned upon as the poor people's insurance. And so it gets treated that way, and people don't necessarily want to identify with that label and utilize it. You have to have a diverse set of accessible physicians in the primary care system to make that happen. You have to have people that patients are going to feel comfortable with in the first place to establish a medical home. So that there are a whole array of factors in the system that are required even once insurance is provided. And this notion of not just culturally competent, some simple things like what hours do some of these primary care practices operate? The 9 to 5 days just don't work for a lot of people. If you think about somebody's working and their kids are in school, a lot of people don't have the luxury of just leaving work, taking their child. Again, if they don't have auto insurance or don't have an automobile because they can't afford it, right? They don't have a car to just hop into. Our public transportation system leaves much to be desired. I think that's why your partners are vast in achieving that issue. I know you had health navigators to assist with the exchanges early on. I'm pretty sure your data will probably say there were some use and utility. I think having navigators who are affiliated with communities that are target areas is a better way of refining that process, to make sure that the navigator is comfortable, maybe affiliated, may have some sense of connectedness when they take those calls. I don't know how you process who makes what responses. I'm just thinking at the top of my head, the friendlier my conversation, the more likely it is I'm going to follow up, right? So if I were on the panel today in my full-on academic, shoulder back, don't talk to me mode, you may not be as attuned or open to what I'm saying. And I intentionally try to make people feel comfortable in any discussion when you bring in new information, because you need to get the guard down so the brain can open up. And so I think in your navigators and the way you all engage, communicate, that's also part of it. But I think it's this network building, what you do on your front end, back to Dr. Martin's issue of keeping it simple. I mean, some of it is just, I have a degree in public health. I have to admit, when I went to the exchange initially with my son, it's like, okay, let me get all the pieces together. Let me get the Affordable Care Act thing, and let me get this thing, and let me get this thing, so I can decision make. That's a lot, right? That's a lot. If you don't have that comfort level and instinct about making decisions, sometimes decisions just don't get made. So there are a lot of reasons why there's underutilization of services, even once they become available. Every new initiative requires a new communication campaign. You can't just post it on the website and say, it's new, yay, because who's going to your website, really? Every day, we're generally not. Pharmacies, networking with pharmacies and having some campaign with local pharmacies who may be better connected to broadcast some of this information, just thinking about your dissemination channels. For the people who know me, you should never ask me for ideas, because
no, we want to partner with you. We want to hear your ideas. They're valuable. And I think that they're going to dovetail right into our next panel, which are, folks who, like you, are very laser focused on this and have thought through some solutions as specific to insurance and insurance coverage, but the things that you're saying, kind of are right on time. I will also tell you, and to Michelle's point as well, and we're eager to partner with really everybody, but Joy Hatchett, who many of you know, who's our Associate Commissioner for Education and Advocacy, is working on a campaign now that is really about education around your healthcare product. So to Michelle's point, you just bought it. Now, what do you do? And so, many times people, they really need help in getting fully integrated into what that product is and making decisions. And even when they've done that, if they encounter a no, they don't know what to do about that no. And so, we're putting together an education campaign that we're trying to get as far into the ground as possible. We do have, a webinar that we've done, and we continue to push out both literature, virtual, and then we're back on the ground now, the MIA. We're out and about, we're at the farmers markets. So that's a critical part of what we do, is when we're standing there, you'll see our big yellow banner, and the folks from the MIA there is to be there to answer, sometimes very straightforward questions about, I don't know how to do X. And that, you're right, knowledge is power. And we all have to do a better job across, whether it's regulators or whether it's, the health plans themselves, in making sure that people understand what it is that they have. So I just want to thank you for your thoughts and your time. It's been really, really helpful. And we want to see the conversation continue. So thank you so much.
One more thing for your brand. And I just think about how you brand and tag yourself, since you have this initiative.
Yeah.
The Maryland Insurance Administration just sounds so non. If there's a sub tag or brand, I know within state regulations that you can give yourself that makes
Mia. So our new brand is Ask Mia. We try to make it personable now, to be able to say Ask Mia, and we've got this great emoji lady.
Great.
Who represents We're Here to Listen. So I'm going to ask Joy to send you to that and get your thoughts about whether you think she's good. But that's what we've been using, and we think that people find it a little more inviting than the Maryland Insurance Administration, which puts me to sleep, that name. So
Yeah.
I guess.
Great. Thank you all. Take care.
You're welcome. So let me introduce, we have, we're very fortunate to have a panel of 3 speakers who really to talk about, on kind of a national level, the role that insurance can play in addressing disparities and inequities in access and outcomes. And the first person I'm very, very pleased to introduce is Dr. Jamila Taylor from the Century Foundation. She is the Director of Healthcare Reform and a Senior Fellow. When I was researching this topic and thinking really where to go, I was so impressed with her work that I was just so pleased that she was willing to come and talk to us today about this topic. And so we welcome you, Dr. Taylor.
Great, I'm happy to be here. Thank you so much, Commissioner Barain, for having me. So waiting to get the slides queued in, and then we'll get started. Great, thank you so much. So I'm going to talk to you all today about the role of insurance coverage in advancing health equity, which is a theme for the conversation today. I did want to sort of frame my talk about how we can advance, right? How we can move forward and ensure that insurance is a part of the vital conversation about health equity, and particularly in this moment that we're currently in this country. I think across the board, all of us are sort of reckoning with issues around health equity, particularly in light of COVID-19. And as was mentioned earlier, this is something that was an issue even before COVID, and COVID has simply magnified this issue. Next slide. So the Century Foundation is the organization that I am here representing today. We are a progressive, independent think tank that conducts research, develops solutions, and drives policy change to make people's lives better. We pursue racial, economic, and gender equity across a number of policy issues. We were founded over 100 years ago by progressive business leader Edward Filene. Next slide. So I'm going to start off with a brief overview of who's getting covered and to share some key stats in this area, how coverage can advance health equity, really thinking through some specific targets in terms of what we mean when we put coverage in the context of health equity. I'll also give an update on federal policy change, particularly around coverage expansions, again, something that you've heard about earlier today. Progress that we've had in this area, and then some recommendations for where we go from here, and then end with some suggested readings. Next slide. So in terms of who's getting covered, I think it's important to sort of ground the conversation in the communities that are most impacted by having shortages when it comes to healthcare coverage. So based on national research, we know that African Americans and Latinx people are still most likely to be uninsured or underinsured. And this is despite the wonderful advancements that we saw from the Affordable Care Act. And COVID-19 has made matters worse. We know that communities of color are bearing the brunt as both frontline workers, as well as those that are most likely to have other health vulnerabilities. And this impacts, their ability to access coverage, and also wanted to lift up here issues around economic inequality and other income challenges are compounded when these communities do not have health insurance coverage. We also know that people of color are disproportionately represented in publicly funded health insurance programs like Medicaid, which we've also heard about today. And then in terms of private insurance, affordability is still a major issue, and really want to take a moment to applaud the great work that Maryland has been doing to make sure that health insurance is more affordable. We know that the average American family spends about 11% of their household income on insurance, whereas African Americans spend almost 20% of their household income. Next slide. So how can coverage advance health equity? These are points that, I have sort of come up with based on my own research and observations in terms of health coverage. I do want to say here, and Dr. Sidnor mentioned this as well, that, coverage alone cannot advance health equity. It has to be a part of a broader multifactorial approach that really centers the most vulnerable communities. And so first, I'm going to talk about how coverage can increase access to healthcare. And again, we know that this is limited alone, and that it does have to go along with other issues. Coverage can enhance affordability. It can also address health provider shortages, and it can help dismantle structural racism and inequality within the healthcare system. Next slide. So in terms of the federal landscape, we have had a number of advancements, even just within the past few months when it comes to healthcare coverage. On January 28th, President Biden issued a healthcare executive order that made it the official policy of the federal government to ensure high-quality healthcare that is accessible and affordable to all. In this executive order, a special enrollment period was also triggered to create the opportunity for folks to sign up for health coverage. We know that COVID-19 not only increased burdens on communities that were already lacking health insurance coverage, but also we saw millions of Americans lose their jobs and their employer-sponsored health insurance. So having this special enrollment period was really key in order to get more communities signed up for healthcare coverage that was affordable. The executive order also instituted an agency review that aimed at determining whether certain agency actions were inconsistent with the official administration policy to protect and strengthen both Medicaid and the Affordable Care Act. We've heard a lot today about the expanded premium tax credits, which were implemented as part of the American Rescue Plan. The legislation also included new incentives for Medicaid expansion in states that have yet to do so. And it included a state option to extend postpartum coverage under Medicaid to at least 1 year. I think this is an important piece to mention because, right now for women who enroll in pregnancy-only Medicaid, that coverage ends just 60 days after giving birth. And in order to adequately address this country's maternal mortality crisis, which has a disproportionate impact on Black women and Indigenous women, having a full year of Medicaid coverage is going to be key in helping to address that issue. Next slide. So during the SEP, we saw 1 million signups, and that's just getting started. And so just really wanted to lift this up as a major advancement in terms of ensuring that more Americans have the health insurance coverage they need. Next slide. So in terms of progress on access, again, a theme today, and I think throughout the conversations nationally around advancing health coverage as well as healthcare access has been COVID-19. Since I put this slide together, this first bullet has actually changed. Now we actually have about half of the US population vaccinated for COVID-19. So now we're looking at about 130 million people in this country, and we all know that we have more work to do. We've also seen expansions in access to treatment for substance use disorder and mental health care, which have also been issues that have been elevated during the COVID-19 pandemic. And also across federal agencies, we're seeing more joint efforts to address the intersectional nature of health disparities. And again, something we've heard about earlier today. One example of this is a HUD and HHS partnership that is focused on increasing access to COVID-19 vaccinations for individuals and families who are experiencing housing insecurity. Next slide. Affordability, this is a biggie and I think a theme that we've heard about today. Again, the institution of free testing and vaccines has been key in terms of, ensuring that those that need these services don't have to spend money out of pocket in order to cover them. And then another part of the American Rescue Plan as well was, having free COVID-19 treatment for Medicaid enrollees, as well as those that are uninsured. Again, a major advancement in terms of the affordability piece and ensuring access. Again, the premium tax credits, which we've talked about several times today. And then we've also seen the federal government adopt rules for lowering healthcare costs in the 2022 health insurance marketplace plan. So again, additional efforts to promote affordability in terms of healthcare coverage. Next slide. Health provider shortages, I think, is another important piece that we need to be talking about more in the context of, I think, both coverage as well as access to care. This administration, as well as even the federal level and Congress have been focusing more on reaching rural communities. Again, I think this is a community that we've sort of seen the ongoing challenges that they've had really elevated during the COVID-19 crisis. We've also seen advancements in telehealth coverage and access. We're seeing more insurance plans, both public and private, covering telehealth, which has been really essential in the context of COVID-19. And I'm hoping that while these advancements have been temporary, because they are included in legislation that is limited, that we do see this continue on. I think consumers have found refuge in being able to access their healthcare providers through telehealth. And of course, ensuring that we also address the digital divide, which I think was also mentioned earlier, in terms of making sure that vulnerable communities have access to broadband and the tools that they need in order to even be able to access their healthcare providers in this way. We've also seen enhancements in the medical workforce, particularly for rural and underserved communities, and increased investments in community-based organizations and FQHCs. And these are usually the first responders, particularly for vulnerable communities when it comes to healthcare access points. Next slide. So I also wanted to talk about structural racism and inequality as a key, a critical aspect in healthcare, not only in terms of, sort of who gets what in the healthcare system, but also a key piece in how we sort of move the country as a whole forward on a host of different issues, but including on the healthcare piece. I think we need to talk more about how structural racism and inequality is ingrained in our healthcare system in various ways, and coverage is a piece of that, but also the conversation about access is important too in this context. So for the first time, the CDC declared racism as a public health crisis, which I think is going to be key in helping to advance the Biden executive order on advancing racial equity. That executive order, I think, was announced on January 21st, so just a day after President Biden took office. And the executive order is really key in calling for a whole of government approach in advancing racial justice in this country. We've also seen more advancements in implicit bias training. Again, this is also something that has come up in the context of COVID-19, particularly how communities of color, particularly Black Americans, some of their experiences in accessing healthcare through our system. And, there are stories that have been elevated in the media where folks have felt that they weren't listened to from their providers. They didn't get the right follow-up care that they deserved. So this advancement in implicit bias is going to be really key, I think, in moving the country forward in this area. And then last here, I'll just mention the Anti-Racism and Public Health Act, which is legislation that was introduced by Representative Ayanna Pressley and Senator Elizabeth Warren, both from Massachusetts. And this legislation really focuses on addressing the public health impacts of racism and calling for innovative approaches to rooting it out of American society, targeting issues like the disproportionate police violence on communities of color, addressing racial health disparities, as well as taking into account the social determinants of health. Next slide. So in terms of where we go from here, I think first, and again, this list could be expansive, and I look forward to hearing my other colleagues on this particular panel to talk through their solutions as well. But first, I think we need to do more to address structural racism within the healthcare system. I think advancements and investments in implicit bias training is important, but bias can also be explicit. So I think we need to do more to focus on how the explicit forms of bias can be addressed in the healthcare system, as well as thinking through approaches to anti-racism in terms of trainings, how we track progress from providers who are trained, whether or not we should be attaching those trainings and outcomes to licensure and certification, and also to how our providers actively engaging in addressing racism and racial disparities among the populations that they serve. Next, we need to continue to build on making coverage more affordable. Again, lots of advancements over the past few months. How do we continue to move beyond that? I mean, there's definitely, a conversation nationally about not only, is it time for a public option, having that available for everyone to be able to access regardless of income level, because we know that even when we have stipulations on income, there could still be economic challenges that families are facing that are sort of beyond the income level. And something like this would also help address issues around income inequality, again, which tend to disproportionately impact people of color, namely African Americans and Latino populations. We also need to implement targeted solutions for those struggling with financial security and communities of color. And then lastly, we need to engage affected communities in the development of solutions. I think too, the COVID-19 recovery is going to be over the long haul. And so really thinking creatively about how we can make sure that the communities that have been hardest hit by the pandemic are involved in the solutions over the long term. Next slide. And last, I'll just end with some suggested readings. All of these are available on our website, tcf.org. They all cover a host of issues from racism and inequality in the healthcare system to Medicaid postpartum coverage, which I mentioned earlier, policy priorities for this year, and some guidelines for reaching universal coverage in America. Next slide. So I'll end there and looking forward to the discussion. Thank you so much.
No, thank you, Dr. Taylor. Very, very much appreciated. I think, what you and Dr. Sidnor have done is given us this really good context and foundation, around sort of the issues that we face, both kind of on an individual basis, in the field today, but, to her point as well, these are not just individual, one-on-one kinds of issues. But I thought that one of your comments, all of your comments are good, but one of the things that you just said that is kind of almost bridging that gap between what can individual solutions versus systemic solutions, and that is recognizing the differences in communities. I mean, people aren't monolithic, right? So, within communities, there's not one community of color. There are communities of color, and they occupy different geographic regions and have different circumstances. And, the idea of engaging communities in the solutions around, well, what are the barriers in your community? So that is insurance, because, I regulate insurance companies, not the healthcare system. Mm-hmm. So, and our healthcare system isn't regulated in that way. But as we begin to look at ways in which insurance plays a role in being able to address disparities of access and disparities in outcomes, all of which is in our best interest to get rid of, because even if all you think about is the bottom line, at the bottom line, you want people to be healthier and to need less serious interventions and less costly interventions. You want people to be whole and healthy and happy for that reason alone, but also because it makes good business sense. So as we think about all of those strategies, the idea of being thoughtful about individual communities and where are places where the barriers are around technology and access in that way, and where are the barriers around transportation. And I would really like to go to the doctor, but I can't take 4 buses when I'm 8 months pregnant and I have a child to get to the doctor. And where are the barriers around food choices? So, what do I do when, I'm in a rush and the only place where I can buy food that's within walking distance, is a convenience store, and I'm going to buy a hot dog. So it's like all of those kinds of things that come into play. And I think that was a really powerful comment, at least for me listening to you. I don't know if anybody else on our Maryland panel has any questions or comments before we move on to the Kaiser Foundation and AHIP, which will begin to take the foundational kind of remarks that you guys have already made, and then talk about how does that play out specifically when we're looking at insurance. Well, I'm going to thank you, Dr. Taylor, but I ask you to hold on, because there may be questions at the end of the panel for all of the panelists. But let me welcome Celeste James from the Kaiser Foundation. She is the interim VP of Branding, Communications, and Community Relations. And I'm very excited to hear from you, as I always am, about what you are doing with regard to healthcare access and addressing health inequities. Ms. James.
Okay, good afternoon. Thank you so much. All right, let me just get out of my full screen. All right. Well, good afternoon, everybody. My name again is Celeste James, and I am the Interim Vice President of Brand Communications and Community Engagement at Kaiser Permanente. And for over a decade, I've led Kaiser Permanente's community health impact investments. And I'm always pleased to talk about the integration of community health, access, and equity. So I want to thank Commissioner Burain and the Maryland Insurance Administration for hosting this discussion. And I really look forward to further conversation. So let me tell you a little bit about myself. I lead a diverse team that works with nonprofits and governments and communities to address identified community needs. And together we have built an extensive portfolio of community investments across Maryland and also in DC and Northern Virginia. And that includes housing and homelessness, socioeconomic opportunity, food access, and access to quality health care. And our particular commitment continues to be to populations that experience inequities and injustice. In 2018, I was appointed by the Office of Maryland State Governor to the commission of, as a commissioner to the Maryland Community Health Resources Commission. And this commission was started back in 2005 to expand access to health services and supports in marginalized communities across Maryland. I also serve as a board member of Washington Regional Association of Grantmakers, which is improving philanthropy in the region, Employ Prince George's, which is creating job readiness and job pathways in Prince George's County, and then Crittenton Services of Greater Washington, which guides and supports girls and young women in DC and Montgomery County toward life success. I began my career in the media industry and corporate communications with news outlets such as USA Today and Gannett Company, U.S. News and World Report, and National Public Radio, or NPR. Next slide. So that's a little bit about me. Now I want to talk about Kaiser Permanente and talk a bit about our model of care that makes a difference in healthcare and health outcomes. Next slide. Oh, sorry, you're on the right slide. Essentially, for those of you who are not familiar with Kaiser Permanente, we own and operate 17 medical facilities in the state of Maryland, and we serve 455,000 members here in the state. We are also one of the largest employers in Maryland, providing jobs to nearly 5,000 Marylanders. So what is the Kaiser Permanente difference? First and foremost, at Kaiser Permanente, we provide both care and coverage, and those two things are deeply connected. This allows our members to get affordable, high quality care and easy access to services all under one roof. And we know that that creates better health outcomes. So our physicians and our clinical specialists are connected through a shared electronic health record system, and it's easy for them to consult with one another on important healthcare decisions and to coordinate care. And that's particularly important in some of the circumstances that we've been talking about this afternoon already. And I'll get into that a little bit more. Also, instead of paying our doctors to provide care when patients are sick, we reward our physicians for meeting clinical quality benchmarks by providing the right care and not just more care, right? We are not a fee-for-service model. Our doctors focus on one thing, keeping people healthy, because we know that healthy people make for a more affordable healthcare system. Third, our members get peace of mind knowing that they don't have to navigate a complicated health insurance and healthcare landscape. We talked about that already, that people, even if they have access to healthcare, they don't always know where to go or how to connect to their healthcare. So as an integrated care model, we're especially proud to be able to provide the value of helping people navigate through a complicated system. And that, again, reduces not only confusion, time spent. Oftentimes when you talk about equity, you're talking about inability to take off work, to spend your day going from doctor to specialist, going from doctor to lab. And so it reduces the need to spend extensive time navigating the system, as well as reducing the need for transportation, although we do provide transportation for some of our members who need it. And then fourth, we partner to integrate social services into our care continuum. This is another distinction that I like to talk about with Kaiser Permanente, because it's critical for healthcare to enable health by addressing not only what's the matter with people, but what matters to them. So it's really important that we ask the question of what are your challenges beyond your health challenges that we can see and that we are accustomed to addressing, but really what are the social barriers that prevent people from being healthy and well? So these are qualities that were especially pronounced, of course, during COVID-19 over the last year. when our members were really relying on coordinated care and our commitment to giving the right care at the right place without delay. Next slide. So here in the Mid-Atlantic, very quickly, we have served for the past 40 years. Kaiser Permanente has, again, the unique role of being both a plan and a care provider. We have 1,600 physicians in the Permanente Medical Group. We serve about 780,000 members, 9,000 employees, and we have 34 medical centers here in our region and 12 core hospitals. We do not have hospitals. Kaiser Permanente does not have hospitals in this region, and so we partner with hospitals across the Mid-Atlantic states region. Next slide. So just to help you to understand where we are in Maryland, we have 18 medical centers across a number of counties in Maryland, and we are expecting more. We're building new centers over the next 18 months. So we'll be showing up in Bowie. We have a center coming soonest in Bowie, in Prince George's County, in Timonium, in Baltimore County, and then in Aspen Hill in Montgomery County. We expect all of those facilities to be up and running by 2022. Next slide. So over the last decade, as we're here talking about equity, let me just explain how Kaiser Permanente has worked to reduce barriers to well-being by focusing not only on healthcare, but on community conditions that drive health. Our commitment to total health has always included a focus on not only people, but places. And so we've been helping to eliminate health disparities and health inequities long before COVID-19, long before the murder of George Floyd. However, I will say that we did recognize that we can and that we must do more to support and end systemic racism and racial inequities. So during COVID, we focused heavily on education and information, as well as, of course, administration of the vaccine. But it was really important for us to operate with trusted messengers in communities and provide informational campaigns to African-American and Latinx communities in particular. We had a campaign that we called a white label campaign because it didn't have Kaiser Permanente's brand all over it. It really was the notion that trusted community messengers would be the best messengers to build confidence in the vaccine. And so we provided the tools, including public service announcements and ads and social media spots, et cetera, so that trusted messengers could easily get the messages out to build confidence in the vaccine. We have been working with barbershops and beauty salons for a number of years to provide health services in Baltimore City. We're expanding that program and doing training for more shop owners and community-based individuals and faith-based communities and so forth. We also released a vaccine equity playbook, and that was our lessons learned, how to set up pop-up clinics in our vaccine sites across the country, where we were doing that across Kaiser Permanente's footprint. Lessons learned about how to communicate effectively about the vaccine, et cetera. We also increased our partnership with community organizations, especially with FQHCs, federally qualified health centers, to increase their capacity to be not only messengers, but to be able to administer the right services and the vaccine to their patients. And that served as an opportunity to exchange on lessons, whether it be about virtual care, which we all increased during that time, and more. So in the Mid-Atlantic, we have an extensive portfolio that goes well beyond community health, well beyond healthcare, and touches on community health. We partner with businesses, we partner with local governments, and we partner with anchor institutions, among others. I'm pleased to talk about, for a moment, a program that we're very proud to be part of, which is called Inner City Capital Connections, where we're advancing small businesses. We found under COVID that small businesses, as you know, suffered tremendously, especially those owned and operated by people of color. And so we've invested significantly in hundreds of small businesses across Maryland and other parts of the region to ensure that they could be sustainable and thriving even after COVID. We invest in housing, both preserving and creating affordable housing across the region. We have a big project in Riverdale along the Purple Line corridor. And then finally, in the last year, we've invested about $5 million in social impact investments, particularly around housing and also in access to food and other benefits. So over the past 5 years, I'll move along quickly, we've contributed more than $600 million to community-funded programs and initiatives to address systems-level improvements, as well as access to care. Next slide. So our commitment to racial and ethnic diversity and inclusion in our own medical centers, in our own organization, has been also critical for us, because we cannot do well in the community if we're not doing well within our own institution. We have a great record of diversity within our organization. In 2020, all across our regions, we had about 53% of our CEOs, direct reports, are women, and nearly 43% of our executive medical directors are women. Also, with regard to racial diversity, nearly 67% of our organization's workforce are members from various racial and ethnic cultural minorities. And we've been recognized as a leader in diversity and inclusion in Diversity Inc. for over a decade. Also best place to work for LGBTQ individuals, and we scored 100% in the 2018 Disability Equity Index. So we're very proud of those kinds of numbers as well. Next slide, please. So our data show that we also have a commitment to equity and inclusion in the way we deliver care. As we work to close racial and ethnic health disparities across our health system, we've been awarded the Multicultural Healthcare Distinction from NCQA, which is the National Committee for Quality Assurance, for addressing racial, ethnic, and linguistic disparities in health. I'm proud to say that all across races, Kaiser Permanente's patients in the Mid-Atlantic with high blood pressure, for example, have a lower mortality rate compared to national benchmarks. And that's in part because every visit to Kaiser Permanente is a blood pressure visit. If you visit the optometry department, you will get your blood pressure checked. If you visit neurology, you will get your blood pressure checked. And so we pride ourselves on providing the right care at the right time, especially for those who most need it, to reduce healthcare disparities. Next slide. Additionally, our breast cancer survival rates for both African American and Caucasian patients are significantly higher than national averages. And that is in part because we provide same-day mammograms. If you come into our medical center, one, you'll be reminded that your mammogram is due if it is. And two, you might be able to get, there's a very good chance that you'll be able to get a same-day mammogram. And even more so, we provide mammogram results within an hour. So our screening processes are very, very strong, and that helps us to get to address chronic conditions in a much more comprehensive way. Next slide. So as I begin to wind down here with just a few more slides, I want to talk a bit about our efforts to close healthcare gaps by addressing inequities beyond our medical centers. As I said, we have, and as you heard today, you know that health is driven not by healthcare, but really driven by the forces that are in our communities, that are surrounding us, what we call social drivers. And social drivers account for significant differences in people's health in their communities, from community to community, from neighborhood to neighborhood. Someone said before, your zip code matters. So we are looking as a healthcare system at access to good paying jobs, access to quality schools, reliable transportation, and as I mentioned before, affordable and safe housing. All of these conditions drive health, and Kaiser Permanente is investing in all of those things as part of our healthcare model. Next slide. So one of the things that we're particularly proud of, and I wanted to end this conversation in talking about, is our addressing of what we call social health, these social drivers of health within the care continuum. COVID, as you know, exacerbated the need for attention to people's social needs. And so to address social needs, Kaiser Permanente had been building a network to assess and address people's social needs. So we partnered with Unite Us, a national organization, to launch the Mid-Atlantic Community Network. And this network connects community members to critical healthcare and social services such as housing, food, employment, and even utilities assistance. Next slide. The network aims to connect clients very quickly and efficiently. It allows providers to view and coordinate and collaborate with each other in providing a client's care. So it enables us to, it's bidirectional in that providers can talk to each other, can track usage of the system, and also we can collect data to identify where gaps in care exist and to improve access overall. So that's that's another way, an important way that we're addressing equity and closing care gaps. Very quickly, how it works is that a community member comes to us. They're connected with a care manager who discovers that they have a food insecurity issue, for example. The care manager then creates a referral to a community provider for food assistance using the network. That provider then is able to help the client identify sources of need or provide that support themselves, and then provide connect them to that service provider. In some cases, it's to transportation, and sometimes it's a financial need that they have. But the bottom line is that the care manager is able to see the client's progress and ensure that they're getting the resources that they need. So this is my last slide, and this is just to emphasize that over the last year, as we've launched the Mid-Atlantic Community Network, we have been able to partner with 280 different organizations who are now part of the network. That includes the Baltimore Mayor's Office of Employment and Development, so it's not just nonprofits, it's local governments as well, Maryland WIC, Center for Urban Families, NAMI, National Association of Mental Illness. And we've invited a number of people into the system. So it's not just Kaiser Permanente's care continuum, it's also community providers who have access to this network and this tool. And we've had about 2,300 referrals since launch in the middle of last year. So we're continuing to grow the network, grow the partnerships, and increase the referrals. And if anyone's interested in learning more about the network, we'd be more than happy to speak with you about it. So I'll just end by saying that Kaiser Permanente values partnership with anchor institutions, local governments, community residents in particular, because we do believe that hearing from community residents is critical to finding the right solutions. We're committed to making healthcare more affordable, more accessible, and more equitable, both by focusing on our own staff and physicians and ensuring that we're reducing any chance of bias in our care, and also by supporting community resources and changing the conditions for health. And then lastly, we believe that social health is a critical piece of the care continuum. We have to shift our thinking about healthcare and the care model, and ensure that healthcare is part of the solution, not only of access to care, but accessible care that meets people's full needs. So with that, I will close and see if there are any questions.
Well, I want to thank you very much. In the interest of time, I'm going to have to move on, but I do very much want to continue this conversation, and perhaps we wind up having maybe even a follow-up session that's very specific to what you have so eloquently described is kind of operating on a multiplicity of levels, but you've talked about what Kaiser as an insurance, as an entity does. So outside of their product. Mm-hmm. So what do they do outside of the auspices of their insurance policy to lift up communities, provide resources to communities? So how do you invest? Where do you spend your resources, your money, et cetera? And then separately from that, although I appreciate the integration, is what do I, if I were a member of Kaiser, what are the kinds of things that I have access to through my insurance product? And you've described a number of things there. And looking at both of those together is powerful. And I think it would be helpful to have maybe a further session to dig a little bit deeper into that, because there's the insurance company as a member of the community and what they invest in the community and support, et cetera. And then there's the insurance company as the financier or, of services and what you get for your premium, frankly, and what is built into that. And I find your network interesting because if I understood it correctly, the care manager that you're talking about that's making these connections is someone who is interfacing with one of your members, so that if your member presents, you see things, that care manager sees things that are barriers to health for that person, and they are connecting them into other resources. And that's very interesting. And I think it will flow right into what we're going to hear from Michelle Jester, whom I'm going to invite to speak now, who's from America Health Insurance Plans. Ms. Jester is the Executive Director of Social Determinants of Health. And I'm very interested in your thoughts as well about some of the concrete things that insurers are doing in their larger role, as businesses and members of communities, but also in their role as health plans, working with their members. So, Ms. Jester.
Absolutely. Thank you so much. As the slides are being brought up, I just want to echo my fellow panelists in thanking you all for bringing this panel and this opportunity together. I know when we talk about addressing structural racism or addressing inequities, it sounds so vast and people may not be sure how to get started, but it really starts with a conversation and sharing strategies, because we won't get anywhere unless we talk about it. So again, I appreciate you all bringing this panel together. So I'm Michelle Jester. I'm the Executive Director of Social Determinants of Health at AHIP. I'm very pleased to be here. Prior to joining AHIP, I've been here a little bit over a year, but I worked with the National Association of Community Health Centers, so FQHCs, for 9 years, where I did a lot of community-led research. Community engagement is a big part and a passion of mine. And while I was there, I led the team that developed the Prepare Social Determinants of Health assessment tool, for those who are familiar with that. We used a very evidence-based and stakeholder-driven process to develop one of the first national standardized social determinants of health assessment tool that was built into the electronic health record. So I've been focused on social determinants of health for a long time. And today I'm very happy to share with you a kind of a high-level overview of unique opportunities our health plans are taking to address inequities, and also provide some specific examples as well. So if we go to the next slide. As has been mentioned before, health equity is impacted by lots of different things. Some come within the healthcare system in terms of accessibility, affordability, quality, but a lot of it exists outside of the healthcare system as well. So in the area of the healthcare system, we find that our health plans have unique opportunities to really leverage their resources, their infrastructure, their capabilities in the following areas to really reduce inequities. So the first area is data. So health plans have a unique opportunity to really provide that more comprehensive, that fuller picture of what's going on within the population. They're able to use their data to really identify where disparities might exist, and then are able to share that data with their provider networks to then really act on those disparities. So as part of this, there are a couple of challenges that need to be overcome if we want to further reduce inequities and advance health equity. One is that we need to improve demographic data standards. This could include race and ethnicity in the sense of going more granular beyond just O&B reporting standards, because if we really want to provide culturally and linguistically appropriate care, we need to better understand the people that we're serving. But we also need more demographic data standards around language preferences, sexual orientation, gender identity, disability status, veteran status, and then also kind of mind, body, spirit. How does spirituality affect how someone wants to receive or access care? So we've actually launched a work group of our member health plans to focus on many of these areas. So over the past several months, we've actually been working together, again, using an evidence-based and a stakeholder-driven process to develop these demographic data standards in ways that would really help inform care. And we hope to be able to use these across our members and also to suggest these to other policymakers or whatnot. If we can have more standardized data, it can really help with interoperability and data sharing as well. Another big component of this is the reviewing AI, artificial intelligence, and algorithms that are being used, and ensuring that the data sets that they're based on are diverse, and to ensure that those don't lead to harmful biases. In many cases, health plans are obtaining these from vendors, and so we definitely need to work closely with the vendors to ensure that diverse data sets are being used in the development of these algorithms and how they learn upon these data sets. Another big portion of this is we need to gain trust with communities, because in many cases, this data hasn't really been collected by health plans before, whether it was just a cultural thing, or whether previously, there were concerns around if this data was being collected, how it could be used to determine eligibility benefits. And so some states had laws against this, but we're in a different space now, that we all want to collect this data and better understand the people that we're serving, but we need to build that trust with communities. And so we need to work with them and other stakeholders to understand why we're collecting this data, how it will be used to inform care, how it will not be used for benefit eligibility, and also how it will be protected and stored and only shared with appropriate entities to inform care. So as part of this, we've also been working on some updated privacy principles and also some data governance principles as well, because at the end of the day, this is an individual's data, this is a community's data. And so we want to ensure that they feel the ownership of that data, and that the provision of this data is voluntary, but that providing it can really help in reducing disparities and really improving care. Another big area where health plans have a unique opportunity to reduce inequities is in their provider networks. So we want to ensure that we're promoting diverse and also culturally humble provider networks. We're viewing this from both an upstream and a downstream lens. So upstream, what can we do to help facilitate people of diverse backgrounds, their ability to go to medical school or to serve in a diverse provider network? So having loan repayment programs, or being supportive of National Health Service Corps, Nurse Corps, those other types of programs that would, pay off someone's medical school or, other type of healthcare service type loans in exchange for serving in underserved areas or in a particular area or network or whatnot. But this goes even more further upstream than that. So how can we ensure that the networks are reflective of the communities that we serve? If only 4% of medical school graduates are Black, and yet 13% of the US population is Black, we have a disparity there. Same with Latinx populations. If only 3% of medical school graduates are Latinx, and yet we have 19% of the US population that identifies as Latinx. So we need to work with the school system. We need to ensure that, even at the primary school, middle school, high school age, that people of diverse backgrounds are being exposed to science, technology, engineering, math, that we're addressing those social determinants of health so that kids can thrive in school and learn. So those are the things that we're trying to do at an upstream level. But if we think about more downstream, because that will take decades to rectify, what can we do now? So what we're focusing on now is diversifying the types of staff that we're including in our care team. So incorporating more community health workers, more doulas, more peer support specialists, people that often come from that local community and can build those empathic relationships with the people that we're serving. We find that's critically important. What else can we do to facilitate someone's ability to find someone that they feel comfortable seeing for care, but while also being cognizant of protecting providers' information? Because we've heard from some providers that they might not feel comfortable disclosing their own demographic information over concerns of being reversely discriminated against. So trying to ensure that we're both protecting that information, but also helping consumers find someone they see for care. But we want to ensure that the people that we serve, we want to ensure that they receive culturally competent or humble, respectful, and compassionate care, regardless of cultural and racial harmony between a care team member and a consumer. And a part of that is training. So something that we've been doing as part of our health equity work group is wanting to develop a best-in-class unconscious bias, anti-racism, cultural humility type training. I know this has been mentioned by some of the other panelists before. Some of the gaps that exist with existing training is that it can often be viewed as like a one and done training or a check the box kind of training. It might raise some awareness around biases, but it doesn't really lead to action at an individual level, at an organizational, or at a systemic level. And so we are hoping to fill in these gaps, have modalities for this training that can be both individually self-paced, but also components that are group discussion, because we feel like this is not something that you can just do on your own and not have discussions about it. So as part of this, we've done an environmental scan. We've identified over 500 minority-owned diversity, equity, inclusion firms. From this list, we developed a set of evaluation criteria that we've then used to score all of these vendors. And so we've narrowed them down to a short list. And we're going to be working with some of these top score vendors to develop this training. And as part of the curriculum development, we've been engaging both consumers to better understand what they would like their care team to know to provide more respectful care. And we've also been engaging providers to better understand what is currently missing from your current training, that would help you develop more respectful and trusting relationships with the people that you serve. So this is something that we hope that could become a gold standard training if we can work with URAC or the Joint Commission or NCQA or others on getting this accredited, and can hopefully help with a standardized training there. Another area that we're exploring are health equity measures for value-based care. We think these are critically important to help incentivize the healthcare system, both insurance and providers, to move towards a focus on health equity, and also to reward those organizations that have already invested and done a lot of the great work to focus on health equity. So with this, we have developed a conceptual framework, measure selection principles, and identified domains that you can see here on the screen. So the domains that we're focusing on are access. So this can include accessibility, affordability, convenience, are services offered equitably, those kinds of things. We are focusing on quality. So again, are they providing and improving upon culturally and linguistically appropriate services? We're focusing on member experience. So are there experiences of discrimination that are being reported or complained about? We're focusing on whether an organization has the right data and the data infrastructure to be able to share that appropriate data to address inequities. Focusing also on community partnerships. Do they have the right partnerships in place? And then we're focusing on some internal things. So does an organization have a culture and structure of equity? And is there accountability with that? So are there public reporting and some transparency around that? So we hope to have this completed by the end of this year, and then we'll do some more socialization with various other stakeholders, and again, also including measure developers such as NCQA, NQF, and whatnot. And then finally, this goes without saying, but health plans obviously implement a lot of programs that reduce inequities. Celeste did a great job talking about a lot of the stuff that Kaiser is doing, and I know the next panel will also go more into details on that. But one thing to reiterate, Celeste talked about this, but in many cases in implementing these programs, health plans are working with organizations on the ground. And then they're also investing in the communities to try to improve the socioeconomic living conditions. And this is not just focused on their own members, this is to benefit the community as a whole. So if you go to the next slide, I did want to touch on social determinants of health, because this is another area, while it's not directly within the healthcare system, this is another area where health plans have gotten heavily involved. And they do this in a couple of different ways and a couple of different levels. So many of you are probably familiar with upstream, midstream, downstream frameworks. So when it comes to social determinants, if you look at the bottom of the screen, one of the most common ways health plans are addressing social determinants is at a downstream level, which is at an individual level. So again, Celeste mentioned this, but a lot of health plans are screening for health-related social needs, and it makes perfect sense. Once you screen for a need, you want to address that need. And they can do this by offering services or programs themselves, or again, in community partnerships where they can refer someone. So an example could be, let's say someone identifies as being homeless or having housing instability. At a downstream individual level, a health plan might provide some housing navigation services or refer them to a housing agency. Or if someone identifies as food insecure, they might refer them to a food bank, or maybe enroll them in a program where they can deliver medically tailored meals to them at a regular basis. Now, this is great for, again, addressing a need that you have identified, but one of the issues with this kind of approach is that you're not really addressing the root cause of the problem. You're focusing on it one person at a time. But you have to start thinking, well, why is this person experiencing housing instability? What's going on there? Why do we have a set percent of our population that are identifying as food insecure. So what you're seeing more and more are health plans moving further upstream, so getting more to a midstream and an upstream level. So at a midstream level, this again is where health plans are investing more in communities. They want to improve the socioeconomic living conditions of the communities in the areas where they're serving. So if we take the housing or the food insecurity example again, a health plan could be purchasing a building to offer transitional housing or permanent supportive housing. Or in food insecurity, they might really work with the community to bring a grocery store or to expand a local bodega or a local convenience store to have refrigerated sections so that they can provide produce or healthy meats and dairy into these areas. But I think one interesting trend in this area, and Celeste kind of talked about this with some of the branding, is more and more health plans don't want to bring in their own program or whatnot. They want to ensure it really is community owned and community driven. So you won't see necessarily a Kaiser grocery store, you know, it would be a community owned grocery store that Kaiser is supporting or something like that. Now at this midstream level, this is really helping to improve conditions, but ultimately you're still working within an inequitable system. So if we take the examples again, why is a health plan purchasing a building to provide transitional permanent supportive housing? Why is there a lack of affordable housing in this area? Or why are grocery stores not anchoring in these underserved communities? You know, what's going on there and what can we really do to start addressing these root causes? So you'll start to see health plans getting even more involved at this systemic, this policy, this structural level of really getting involved in advocacy. That a lot of the social determinants of health and health inequities ultimately result from discriminatory policies or inequitable investments in communities. So what can we do to change that? So with housing, what can we do to advocate for more affordable housing options or affordable housing policies such as housing vouchers, those kinds of things? For food or for jobs, what can we do to help encourage businesses to anchor in underserved areas? What can we do to encourage businesses to offer living wages so that people who have jobs or working multiple jobs can put food on the table? You know, those kinds of things. So next slide. I just wanted to end with just some specific examples of how health plans have been addressing inequities during COVID. So this has been mentioned before, but obviously a huge inequity has been the digital divide, such that some people have been able to take advantage of telehealth or our new socially distant digital world, and others have not. So many health plans have stepped up and have provided phones with data plans so that people can access telehealth or again, engage in this new digitally social world. Digital literacy has also been an issue for some communities. And so we've had several of our health plans offer technical assistance type programs to build digital literacy. So that could be how to navigate a lot of the online platforms or portals, or for many people whose English, who are limited English proficient, you know, how to navigate the online systems to get to an online translation or interpretation service, because oftentimes it needs you need a little bit of English to get to that point. Another way they've been approaching to bridge the digital divide is a lot of health plans have community resource centers that are kind of anchored in communities and they provide a lot of services. But obviously these had to close during the pandemic. But what they've been able to do is transform these community resource centers into still centers, but they provide free public Wi-Fi so anyone can use them. And they've also set them up so that you can use the office space within the center to schedule a telehealth appointment and take your telehealth appointment in that private office space, because something else that's been happening as we've all been moving to telehealth, some people don't have private spaces to take their telehealth visits. And this is particularly important for behavioral health telehealth visits. And so with this, you can schedule an appointment. It has a computer and a webcam, and you can take advantage of these private spaces and the free public Wi-Fi for your telehealth visits. Accessing COVID-19 vaccines, this has been talked about before, but we, in conjunction with many of our members in Blue Cross Blue Shield Association, launched a vaccine community connectors program with the White House earlier this year. The main points of this is to really help reach those hard to reach populations to ensure that they get equitable access to the vaccines. And so what health plans have been able to do in that respect is outreach to a lot of the members, assess whether they've been able to get the vaccine. If not, are there some socioeconomic barriers that they can address, whether it's transportation, or whatnot. They've been able to work with pharmacies to block off scheduling appointments to ensure that these people can access vaccine appointments. And for those that may not be able to go to a certain site, such as the homebound, a lot of health plans have been serving as like the stewards of logistics and the administration. So they will handle the vaccine scheduling appointments and then handle the logistics of bringing in an EMS or a health home agency staff to come to a designated area, pick up their vaccine doses, their list of appointments, their PPE, and then they can go administer these vaccines to homebound populations. And so that's been really successful there. And then finally, just social determinant of health inequities that have emerged during the pandemic. Many of our health plans have had for years, this is prior to the pandemic, but they had connections with local employers that still continue to hire during the pandemic. So they were able to connect people with jobs that were available during the time. Things had to change a lot during the pandemic. For example, you can't refer people to a food bank because the food banks weren't allowing people in. So they repurposed their medical transportation vans to bring food to people in need. Or again, as social isolation and loneliness became a huge issue for many people, many health plans launched or expanded programs that paired kind of volunteer pals with people who identified as lonely, and those people could help with just being there, building a relationship, helping with some chores, and just, being someone during a really tough time. So if you go to the next slide, I'll just end there. I know we're close to time, but I just, again, wanted to thank for the opportunity to share, and I appreciate the things that Dr. Taylor and Celeste also mentioned. So thank you.
No, I appreciate that. And I wish we did have time for questions or comments, because your presentation, is so filled with information. And I know we're going to need to continue this conversation, but I do need to move to the next set of panels, because I think we have a couple people in those panels that have some hard stop times. So thank you. I think what we've done now is we've had the ability to kind of create context around, what is the quote unquote problem that we're addressing? What are the issues? What are the drivers of those issues? What are kinds of things at a high level, looking mostly nationally at the kinds of things that insurance companies can do? And now our next panel is really going to be bringing it now back to Maryland and thinking about and talking about some more specific things that we're seeing from folks within our own community here. And the first person that we're going to hear from is Joe. Are you there?
I am. Hey, Commissioner.
Joe Pinty, I wasn't sure whether you were going to be able to stick with us. Joe is the CEO of the Mid-Atlantic Health Plan for United Healthcare, and very, very happy that you're able to talk with us today. And I think you have some other members of your team with you as well.
Yeah, and I'll hit that just to kind of jump in. So thanks so much for having us. And I guess I learned something new every time I participate with you. Mia, is that how we're going by now? Mia?
So what we've done, no, we're still the Maryland Insurance Administration, but what we've done is
Asking Mia.
We've branded Mia as the person who is there for you.
That's great. Good. Well, I applaud the Maryland Insurance Administration for having this conversation. And really, it's great to hear the industry having a conversation that has, the problem and the solutions and the effort has been around for years. But the ability to advance and talk about this has always kind of remained a little bit stagnant. And you know what? I think some of it is because sometimes people have thought about the word health inequality as people not getting maybe the right care, or, avoiding care, or getting a duplicative test. I mean, those are all the things that could happen. But when you really get under the heart of what is going on, we think about health inequality as, addressing, and I thought Michelle teed this up great for us. It's an upstream problem that has to be resolved with a downstream solution. And so, the way we think about this in Maryland is that we have to look at each individual and get engaged and look at their societal, their economic, medical, educational disparities. And when we do that, right, we have the ability to then get the right care at the right time. But we also got to make sure that the provider community and also, our clinicians that United has ownership of in Maryland, that they have a cultural awareness of the community and also very aware about diversity and inclusion. A lot of people talk about it, but don't live it. And so I thought it would be best that we gave Dr. Stiff, who leads our regional and kind of company strategy that talks about the upstream actions on what we're doing. And then we will pivot right into Landis Rush, who is also on the call with me, and talk about the real downstream solutions that we're advancing health equality with in the state. So Dr. Stiff, I'll hand it over to you.
Great, thank you, Joe. So the next slide, please. Great, pleased to be here today. And unfortunately, I have not been on the entire time for the presentation. So hopefully I'm not repeating some of the basics that many of you are probably aware of. But I wanted to highlight the landmark study, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, that was published by the Institute of Medicine in 2002. This study identified race and ethnicity in addition to socioeconomic status as factors impacting healthcare delivery, is what we've been talking about today. But the most important thing to highlight for this study is that they identified, in terms of interventions, that we must have a multi-collaborative approach throughout our healthcare delivery system. And I think it was the first time that health insurers were highlighted as an important stakeholder in really addressing these health and healthcare disparities. And what we've talked a lot about today, our current pandemic with COVID-19 has elevated this issue of health and healthcare disparities among people of color to a national level and is at the forefront of the conversation. And I personally don't recall at any point in my long healthcare career where there's been such an openness throughout the community to recognize these disparities and to develop solutions to address. So I want to chat first, as Joe outlined, about our national/regional approach. And if you go to the next slide, please. Just wanted to share with you what we've done across our enterprise to advance health equity. And we've supported efforts to help reduce health disparities for well over 15 to 20 years through our continuous work to identify and address and monitor health disparities associated with age, gender, address, race and ethnicity, sexual orientation, language, and also disability. And we've developed a cross-functional approach throughout our enterprise and really to identify those gaps in care and outcomes and tailored appropriate approaches to closing those gaps. The Health Equity Services Program ranges from our Clear Advocate for Me advocacy program or our customer service program, data, which includes customer and market specific analyses around disparities, clinical interventions, and marketing, which is really critical for supporting those tailored engagement solutions. In addition, we have multiple initiatives and programs throughout that stand up throughout our enterprise, such as our diversity and equity and inclusion work, health literacy program we've had on board for at least 15 years, our cultural competency and bias training for our staff, but also, of course, free of charge to our network, and a robust supplier diversity program. Next slide. Next slide, please. Oh, thank you. So I know I'm preaching to the choir, and you all are very aware of this data I have addressed on why it's important for us to identify and close our health disparities. Lots of factors impacting member retention, satisfaction, our star ratings for our governmental programs. But I wanted to highlight at least a recent study that points out the economic gains to our US healthcare, our US system, if we were to address racial health disparities. We'd have $135 billion in gains, economic gains, if those disparities were eliminated. $93 billion in saved medical costs and $42 billion in productivity. Next slide, please. So we're well aware of what drives health outcomes, and we all know, especially on this call, that research has shown that just 20% of health outcomes are due to what actually happens when you go to a doctor's office. 80% of what impacts a patient's health and their outcomes determined by those non-medical factors, such as patient behaviors, access to transportation, lack of housing, good nutrition, education, among many other things. And as we all know, these are what we classically call the social determinants of health. And it's very critical to know and to realize that where we are born, where we live, work, play, and age all impact our quality of life. So really critical in our discussions of our health disparities and improving health equity. Next slide, please. So in terms of those social determinants of health, our Advocate for Me program has a robust system in place to really identify those potential gaps in care. It goes everything, begins with training, well, selecting the correct advocates to be in place to not only handle medical benefits, but all of these very other important assets and that really are critical to member outcomes. And so our advocates listen for cues and clues, information that comes in through their dashboards from our claims system that includes the CMS, the Center for Medicaid and Medicare Services, Z codes to help identify those individual members who may be calling in just to find an in-network doctor, primary care, or even an orthopedic doc, wanting to know whether their MRI, where they can get an MRI. And then our advocate can search a little further and look in the dashboard and see that not only are the clinicians, our nurses trying to reach out to these individuals, but also there are some indicators that they have some financial needs. And so they can connect members through the dashboards and to our database and system that we utilize to help close those gaps in care, helping them with things such as ways to pay for utilities, to purchase of medications. And so really connecting our members to those critical services that really give that holistic approach to their care and their outcomes. Next slide. So just want to highlight some of our cross-enterprise initiatives that are advancing health equity that apply to the region and to our local markets here. I want to point out about the development of those new codes. United Healthcare worked with the American Medical Association in 2018, 2019, and wanted to move away from just the system had ICD-10 codes in place to help with social determinants of health, but there were only 10 codes. There was one code, for example, that just addressed the economic issues. So a broad, very broad category of individual has economic issues, and it didn't get down to specifics such as paying utility bills or needing help with their pharmacies, paying for their drugs. And so we proposed 23 new ICD-10 codes or Z codes to the CMS and the CDC, and those were approved in November 2020. So this is really going to help build to get those codes in the system and really make it easy for us to identify individuals with those additional gaps in care. We've got lots of programs for our LGBTQ populations as well, web-based training for advancing health equity that is available for all of our staff as well as our networks with no charge, free of charge. Our COVID-19 vaccine toolkit, which is very timely as we are dealing with the pandemic, really to address the vaccine hesitancy in our communities of color. So just wanted to give you a sense of the background of the United Health Group, United Healthcare's health equity efforts, our systems, our support in place. And then I want to turn it over to Landis as he talks about all the work we're doing in the Maryland area.
Thank you.
Good afternoon, everyone. I want to thank Kathleen again and the Maryland Insurance Association for the opportunity to present today about a lot of the great work that we're doing in Maryland specifically. Again, I'm the National Vice President, Public Sector Labor. I have a lot of different hats. One of the roles that I play for our organization is the work that we do in communities across the country. I'm based in the Washington, D.C. metro area. I'm very passionate about this work, having come out of the non-for-profit sector for most of my career. But we got started with this supporting underserved communities initiative, the way of thinking, taking a step back and taking more of a holistic approach or view, and how are we sort of showing up in these underserved communities? What is it that we could be doing better? What are the gaps? What are the challenges? So we decided to hire a third-party independent researcher at a Brown University to do a study. We convened 4 focus groups with literally the community. I'm talking not just residents, but providers, elected officials, the business community, faith-based leaders, to listen and learn from them what we could do better to help try to solve for the just enormous amount of challenges around health inequities, social determinants of health. Next slide. So this initiative I'm referring to is initiated by a public sector and labor segment health plan leadership team. Again, it's to deepen our connectivity within diverse underserved communities, impact racial and social determinants in healthcare. As we all know, racial and social disparities are very different in many ways, and we wanted to focus on both. And then obviously we wanted to deliver a really good societal return through the deployment of products and programs that improve the health of those individuals living within these communities by zip code. And also reinforce United Health Group's presence as a philanthropic community partner. Next slide, please. Our team's focus was really on 4 areas, obviously Washington, D.C., more specifically, Ward 8. I think most of us on this call, I think we can all argue that, if you look at the data, Ward 8 is arguably one of the most challenged wards in the district. Also, obviously, Baltimore, Montgomery County. I know when folks hear Montgomery County, they say, oh, wait a minute, Montgomery County is a wealthy county. However, they do have pockets of poverty. So we're going to be focused strategically in a number of their communities as well. And obviously Prince George's County, Maryland as well. The concentration on these underserved communities where relationships have already been established and nurtured. That's important because in many of these communities, trust is so important. It takes years sometimes for folks to open up, particularly if you're coming out from the outside, as many of them will say, corporate world. So we've got some really good relationships in these places, and we're going to continue to expand on those. Also bringing together a diverse group of UHC and Optum employees in business areas, and connecting with diverse local partners in leadership positions for feedback and consensus around project scope. And when I say diverse local partners, we're referring to, it could be NDE, supplier diversity partners, again, non-for-profits, you name it. Next slide, please. As a part of the focus group, which was, and I want to be fair in how I state this, it's extremely difficult. You guys got to think back when we did this. This was back at the height of the pandemic, around last Thanksgiving. I think Prince George's County was seeing a big spike. Most of the country was. And these folks still took an hour, hour and a half. Some of them came on twice. High-level county executives, chief administrative officers, all the way down to very busy faith-based leaders and business leaders, to listen in and provide engaging feedback on how they see it versus us, United Healthcare, coming in saying, here's what we think your problem is. Here's what you should do. We wanted to hear from them and then have their feedback. We wanted to take their feedback to inform our next steps. So we generate a lot of great ideas for different programs from this report that came out. We identified ways to reinforce United Healthcare's presence. Some of the key findings show multiple needs, obviously social determinants of health. Again, we've all said this earlier, the pandemic has only increased awareness and sort of shined a light on how real and serious this issue is. Obviously improved healthcare, not just from a quality perspective, from an access perspective, cost perspective, help manage chronic diseases. In most of these areas where we're focused, obviously high blood pressure, hypertension, heart disease are rampant. So we've already started the program. So we're doing some health screenings and a number of these different events that we've already established. Increase people's awareness about lifestyle changes. That could be around health literacy, health education, which is so important as we continue to move forward in our initiative. Next slide, please. Listen, for over several decades, United Healthcare has been identifying, addressing, and monitoring health disparities and health equities. It's nothing new. We've been very engaged. Again, COVID-19 has only highlighted the rates of disease, complications, death are higher for people of color and underserved communities. We also want to address racial and social disparities in healthcare, deploy products and programs that improve health, and reinforce our presence as a philanthropic partner and help establish United Healthcare as a local hometown presence versus a large global company. Next slide, please. And again, from the 38-page report that was developed by our independent third-party researcher out of Brown University, what was interesting that came out of it, from all of these leaders in this high-profile folks that on the ground, local folks on the ground that's been doing this stuff for 20, 30 years, food insecurity continuously came up. It was just amazing. It's like, look, if people can't eat, you can forget about all the other stuff. And they're right. So food deserts, obviously, chronic conditions and comorbidities. So what we've done since then is we've got these monthly events, and we've just launched 2 in Ward 8. We've done one in Prince George's County already. We're getting ready to do another one in Prince George's County, where we literally have clinical folks come out, pop-up tent, and we're doing health screenings. And we've got food trucks that come out with vis-a-vis local partnerships with community-based, Capital Area Food Bank for one, and we're literally serving food to folks who are in desperate need. Can't tell you the number of folks, grandmothers with 7 children, who've come up to me to hug me and say, Lance, thank you so much for what you're doing. I said, listen, I'm from the inner city. I grew up in this myself. I'm just blessed and fortunate to be in the position I am. I feel like this is not work. This is service. This is something that we're supposed to be doing. But the impact and the response has been so significant, just simply feeding people. We haven't even gotten to the comorbidities yet. They just want to get a meal.
Yeah.
So from that perspective, this has been just one of the most rewarding things I've ever done in my professional career over the last 25 years. In addition to that, we've made this fun. We've got music out there, a DJ, we've got food, we've got the clinical folks out there doing the health screenings. We wanted to give people a sense of dignity and pride versus you show up, you throw a bag of food in their car and tell them to go. No, we want to make this a community health event. And it's turned out great. Next slide, please. So our approach meetings communities where they are. I think I talked about this already. One partner organization event per month. I kind of already alluded to this. Add on a supportive element that aligns with core priorities, engage local staff and members of the community to collaborate and build trust. The community is so important in this initiative. Without the community, this will not work. We want them to own it. This is your event. We're here to support you. Become a catalyst for large scale systemic change across the health system. Next slide, please. Last but not least, I think this slide sums it up. If you can see the photo to the top right, there's a picture of a very dear friend, Angela Alsobrooks, CEO for Prince George's County. She came out, this was one of the holiday food drive events that they do every year. We were one of the partners there. I got to tell you, we served over from 7,000 to 9,000 families. 2,500 cars came. This was in November, like last year during the peak of COVID. And the number of folks that came through, it was just overwhelming. And it just sort of talked to you, put more sense around just how serious this food insecurity issue really is. And I gotta tell you, County Exec Brooks told me firsthand, Lance, this is incredible what you guys are doing. Keep up the great work, and we will continue to do more. So I'm gonna stop there. Again, I wanna thank the Maryland Senior Association for the opportunity.
Well,
Thanks.
thank you all very, very much. You know, what you're doing is really, it's impressive. And, you know, I want to continue this conversation between carriers as community members and businesses within communities, and then carriers as part of their product design. And, you know, because they're kind of different places, but they're both really important. And I have lots that I'd like to still hear and talk about, but we are really late on time, and I want to try to be respectful of people's time. So Joe, if you want to maybe give it a minute, and then I'm going to introduce Care First.
Yeah, no worries. No, and it's great, right? We're all part of the same opportunity
Absolutely.
to solve this in Maryland. So it's great that we had Kaiser participate, Care First as well. And I would just close with, you know, this was just a tip of where we're focused. And I thought Landis and Dr. Stiff just really presented, you know, the topics well. But there is even so much more in regards to things that we're finding from these focus groups, things around an increased depression and anxiety, right? And knowing what the challenges are there to get behavioral health through telehealth, which we're doing, but then line up with an organization like Mary's Health Center, or even looking at domestic violence has increased because of all the people staying home, and then working with organizations in Maryland like the House of Ruth. Those are all things we didn't even talk about that we're all doing as well. So we'll continue this conversation in the future, but just thanks for allowing us to be part of it, Commissioner.
No, absolutely. And we will continue this conversation because my head's on fire. So let me make one kind of housekeeping announcement, and that is that my chief of staff is going to take my 4 o'clock White House, briefing call. And so I'm going to stay on until 4:30. Everybody is welcome to stay on. I want to make sure that we get through all of our, obviously, that we have 2 invited panelists, and then we have 5 registered speakers. And I know there have been a few other folks who've asked to speak, and hopefully people are still hanging with us. But I will go beyond 4 o'clock to make sure that anybody who wants to be heard is heard. So let me now move to Dr. Schangemeyer, who is the Chief Medical Officer of Care First. And thank you.
Good afternoon, and thank you, Commissioner Barain, for the opportunity to share our perspective on this important topic. I'm just gonna wait for the slides to come up. Yep.
Can you see them? We've been having a few technical problems ourselves here today.
There you go.
Thank you.
Thank you. So thank you again, Commissioner Barain. My name is Dr. Tej Schangemeyer. I'm the Chief Medical Officer for Care First Blue Cross Blue Shield. I'm new to Care First in Maryland, and I've been here for a little less than 3 months. I joined Care First from New Orleans, Louisiana, where I worked in Medicaid for a large national payer. And I'm a family physician by training and spent the most part of my medical practice days in large academic health systems and small federally qualified health centers, taking care of diverse people from all walks of life. I'm originally from Zimbabwe, Southern Africa, where I went to medical school and practiced for a few years before relocating to the United States. And during this time in Zimbabwe, the HIV epidemic was at its peak. And I witnessed heartbreaking disparities in HIV care between the haves and have-nots. I share this background with you all this afternoon because it has shaped my deep desire to help find sustainable solutions that will help provide equitable access to healthcare for everyone at a systemic level globally. And we've heard from a lot of my colleagues this afternoon that this last year has been a challenge for all of us because of the COVID pandemic. And this horrible pandemic had a different impact on different people. Older folks and people of color were affected the hardest. And it's not news to a lot of us here that COVID highlighted disparities that we already knew existed. And that's why we are here today. And on the next slide, I'd like to talk about what health equity is. And Dr. Sidnor did a really good job giving us a background of health equity. Here at CareFirst, we want to go to the aspirational language by the Robert Wood Johnson Foundation, who defined health equity as everyone having a fair and just opportunity to be as healthy as possible. A fair and just opportunity. And this means removing economic and social obstacles to health, such as poverty and discrimination, like we have heard. And early on in my career as a practicing family physician, I quickly noticed that the majority of influences on my patients' health happened outside of my office. And I also quickly learned that we were not going to eliminate poverty in my office, and that we could not solve for systemic discrimination in my office either, nor in the hospital. In fact, it was clear that we needed a multi-sectoral, multi-stakeholder, multidisciplinary approach, bringing everyone together to achieve this aspirational goal of a fair and just opportunity for everyone to be as healthy as possible. So this afternoon, I just wanted to pay particular attention to what payers and organizations like CareFirst can do to address health equity. And we do have an important story to tell, an important role to play to impact change. First and foremost, I think we need to align amongst ourselves and collaborate. And if we do that, there really is a tremendous opportunity to make a difference. It starts with a commitment to work on some of the root causes of inequities. So for example, CareFirst, with other 36 independent Blue Cross and Blue Shield companies, along with Blue Cross Blue Shield Association, united in a pledge to build a stronger future together. And in this pledge, we included being a loud, clear, and constant voice in our contempt against racism, hate, discrimination, and violence, and boldly denouncing racism throughout our communities. The pledge also included committing to removing barriers, preventing equitable health, well-being, and safety for all. And this will all happen through various strategies, which I will address later. On the next slide, I wanted to just reorient ourselves with how big this problem is. And I'm not going to spend too much time on it, but it is clear, both locally and nationally, that there are healthcare disparities that exist among racial and ethnic minorities and other underserved populations across mental health, chronic conditions such as diabetes, maternal health, and access to preventive health such as immunizations. Well, here in Maryland, we have seen disparities in vaccination rates between rural and urban counties, between affluent and low-income zip codes, and across race, with Maryland counties with the highest proportion of Black individuals having the lowest proportion of fully vaccinated individuals. So on the next slide, the big question that I want to answer is, what can we do about this? And what can health insurers do? Well, Ms. Jester from AHIP has done a really good job summarizing some of this information. And I want to reiterate what she has said. Insurers, including CareFirst, have been working on this for several years. That being said, there is still a lot of work to be done, and disparities still exist. So we cannot stop now. And in fact, we should double down and continue to engage and invest in reducing disparities. So I summarized what I think we should be doing going forward in 5 buckets that we can prioritize that I'm just gonna talk about next. The first one is data and analytics. We wanna collect data and analytics to measure disparities. Data is crucial to understand the hard truths, know where we are, and what progress we are making. Incomplete and inaccurate data is one of the barriers to continued progress towards health equity. Specifically, right now, the challenges that we're having is not having complete and accurate race, ethnicity, and language data. And there's also an opportunity for organizations like ours to continue to strive for integration of data from electronic health records and claims platforms, as well as using advanced analytical methods to come up with actionable insights that help us get to where we want to go. The second bucket that I want to focus on is continuing to work with our healthcare delivery partners to move towards value-based care. Value-based care has been shown to improve quality, the patient experience and outcomes, to expand access to care, to improve affordability of care, and most importantly, to address equity by addressing the overall health of the entire patient population and also focusing on health beyond the 4 walls of the hospital or the clinic. And then the third one is, we've heard from a lot of my colleagues this afternoon, that we want to continue to invest strategically to improve social, economic, and health outcomes. Investing in initiatives that have a positive impact on social determinants of health, the conditions in which the environments where people are born, where they live, learn, work, play, and where they worship. And such conditions such as access to affordable housing, quality education, public safety, local health services, and like we've heard earlier, even access to broadband internet service. And then the fourth one is to continue to engage and partner with community-based organizations, public sector, and others to improve community health. Public-private partnerships and close collaboration with the community will create a more equitable healthcare system through local programs and initiatives. We want to provide resources to better equip community health organizations for success. And this means working with and for the community partners rather than making decisions to them. I believe no one knows the health of individuals in a community better than those working in the front lines. And Commissioner, last but not least, we want to continue to advocate policy decisions at the state and federal levels to reduce disparities. And this could be advocating for public policies that aim to improve access to health coverage and supporting efforts like the CDC's recently announced initiatives to address racism as a public health threat. So at CareFirst, our mission is to improve accessibility, affordability, and overall quality of care for all members and communities. By focusing our efforts on addressing social determinants of health, it will drive impact and lead to better health outcomes and healthier lives. On slide number 5, I would like to end by a quote from our CEO, Brian Pinnock. And Brian is always good to remind us that this work is just beginning. I know we've been doing a lot in this area, but we cannot accept this reality, and we can do more, and we must embrace the need to change, each one of us individually and collectively as a society. When I look at the state of the world right now, sometimes I get discouraged. The obstacles we face are huge. That being said, I could not be more hopeful for the future. I mean, this afternoon, it's just evident that there are so many of us willing to put our heads and resources together. And I think together we can make a meaningful change. We can start right here in our very own state. I know nothing will change overnight, but I believe better is possible. And I also know that I'm new to Maryland, but I really look forward to meeting with you all and working with everyone to continue to strive to improve the health of all Marylanders. And in the interest of time, I'm going to stop here. And thank you again, Commissioner Barain, for this opportunity to share with you. And I look forward to the continued conversation.
Absolutely. Well, thank you very much, Dr. Shingomera, and welcome to Maryland. I know you've been here a little while, and I'm excited to work with you further as well. You know, I have an idea percolating in my head about a work group, because we've heard so many things. And, you know, I think many carriers and health plans are kind of on the cusp of how to drive this into their health products. And so I think that's going to be a very interesting, you know, conversation around, you know, I think about the wellness products that are available to me and which of those wellness products, who they're accessible to, and are they the right wellness products? And I think that there's a lot of interesting conversation. I'm not in the business of dictating product design. That's something that carriers do themselves. But I think we can have interesting conversations about that. So thank you. Thank you so much for your remarks today. And now I'm going to invite John Gorman, who's the founder and chairman of Nightingale Partners, to talk to us as well. You know, what we've been on the journey today is kind of moving from the big picture into what does this really mean on the ground, you know, for people, for what companies are doing in the field and the impacts of that on individuals. So John, you're gonna be our last speaker on that point in our invited panelists, and we're excited to hear from you.
Thank you so much, Commissioner. It's just wonderful to be here. And Michelle, thank you again for having me included in this this wonderful session. I've never participated in one like this with an insurance commission. I think it's wonderful. I'm John Gorman. I'm the chairman and the founder at Nightingale Partners based in Washington, D.C. We are a fund that offers analytics, design expertise, and sustainable financing to directly impact social determinants of health. Most of our investments include broadband internet access, the deployment of community health workers, and much of our focus is on food, housing, and in transportation security. I'm thrilled to be the only investor here today, but I also realize I'm the last thing that's standing between you all and a cocktail. So if we go to the next slide, that'd be wonderful. Actually, and just keep going if you would. That's wonderful. So today I'm going to just go over some data sources that all plans have at their fingertips. I'd like to show you some of the supporting evidence around why investing in social determinant of health interventions makes such great sense for insurers to engage in, and then the 5 steps that we undertake to successfully launch, finance, and operate these interventions. I want to just say at the top that I hate this phrase, social determinants of health. For me, it's kind of like how we call cow meat beef. It's a sanitized term that removes inspection of what makes us uncomfortable. Social determinants of health are just 4 fancy words for poverty and racism, full stop. And you know, I think the more that we recognize that poverty and racism are attributable to 60 to 80% of what we spend in our healthcare system, and that frankly, poverty charges interest in healthcare. You see a lifetime of poverty and systemic racism reflected in astronomical healthcare costs among elderly people of color in particular. So this is really where our focus is as an investment fund. And if I had 3 wishes for those of us on this call today, they would be: 1, in product design, that we look to reduce and or fully eliminate copayments and deductibles, which, let's be frank, are just, you know, economic barriers to access, especially for the low income and for the vulnerable. That we include anti-poverty and racism interventions in medical loss ratios. Fundamentally, when we engage in these activities, these are all designed to improve the quality of care and to reduce the cost of care. And I think that these expenditures on behalf of insurers really belong in the calculation of the minimum medical loss ratio. Lastly, that health insurers recognize finally that when we are all at 100% risk for our members' healthcare costs, that we are de facto social service agencies as health insurers, and that we really need to start acting like that, and to move away from, you know, the traditional commercial mindset that many insurers have, that, you know, we have gone running like scalded dogs from vulnerable populations and the providers that serve them, and recognize that these are the partners that we need to really bend this healthcare costs curve. And the only way to really do that is to fully and directly address poverty and racism in the services that we provide. Next slide, please. When we look at the sources of data that are available to health plans, it's a staggering amount of information. And that if this data is not put into actionable format, it really just ends up being noise for both insurers and providers and the community-based organizations that we rely on to address poverty and racism in our communities. So when we look at just the scads of data that are available, when this is done right, this is what informs intelligent design of anti-poverty interventions. And so we all know that health plans collect claims information, that we conduct health risk assessments, that we have an enormous amount of information available in our electronic health records. But what we also need to start looking at is the publicly available data that really gets into what poverty and racism look like in our community. So for instance, when we are beginning to design an intervention to address these factors in some of these communities, and we're doing a big one right now in West Baltimore and elsewhere in the state of Maryland, that we're not just looking at claims information, but that we're looking at factors like who checked into the shelter system in the last 2 years, whose home was, were they evicted from, or were they foreclosed on in the last year and are therefore housing insecure. All of this data is available from external public sources, and we use all of it in all of our investments. As you can imagine, when as investors, and our syndicate of investors tend to be very high net worth individuals, they want to know that their money is being spent on the folks who need these services the most, and they want to see right down to the penny and to the individual what the impact of these investments are in these communities. So we are very data driven, and we really rely on results and on established academic studies, as we go to the next slide, that that really underpin all of our investments. These are just a couple of very short examples. We've got a whole library of these studies available on our website at nightingalepartners.org. But the one that really got me into this field as an investor is that very first one you see there. And that was the landmark study at Geisinger a couple of years ago, up in central rural Pennsylvania. Geisinger realized they were spending on the magnitude of $300,000 per patient per year on their uncontrolled elderly diabetics. So they started a medically appropriate meal delivery service for these uncontrolled diabetic seniors. And within 14 months, they had dropped the average cost of each of those members to $48,000 per member per year. So net of the cost of the meals prepared, delivered, they saved on the magnitude of almost $200,000 per patient per year. As an investor, that's a 35x return on investment. And unless you bought Bitcoin last May, nothing on this planet will get you that kind of return than food security. You see some of the other studies that are here. It's been attributable to $4 billion in unnecessary health spending nationally, that we have such rampant transportation insecurity among so many millions of vulnerable Americans who just simply cannot get to a doctor's appointment or to an urgent care instead of in an ambulance to an ER, or to a pharmacy to fill prescriptions after they've been discharged from the hospital. So we know that these interventions work, and that as investors, these are some of the most impactful investments that we can make, and really is only the true path to bending the cost curve for the folks that actually are most attributable to healthcare spending in this country. If you go to the next slide, please. So we use all these scads of data. We look at 5,000 different sources of publicly available data, plus the medical, pharmaceutical, and behavioral health claims from our health insurance partners to do hotspotting of the communities in greatest need. And then with that claims data that I mentioned, this enables us to take this analysis right down to the individual level, and then to be able to aggregate up by neighborhood, community, in some cases counties, and whole states. And we have these very specific dashboards that again go right down to that individual level that tell us where do we need to focus our investment dollars, and what are the very specific interventions that are going to be needed to meet the needs in these vulnerable communities. Next slide, please. We also will do a very exhaustive scan of the environment in the communities in which we're going into, because we know that once we begin offering these benefits and services, we're not going to be taking them away. These are going to become permanent fixtures of the benefit designs of our health insurance partners. And so therefore we need to understand who's available on the ground in terms of existing community-based organizations that we can rely on, that we can help leverage, that we can help them scale, so that they can provide these types of benefits and services sustainably and permanently. So for instance, in looking at a scan we just recently did in San Diego, we found that there were over 200 food pantries available in San Diego County, but only 2 of them were within a 20-mile radius of the most vulnerable members with diabetes. That only 28% of farmers markets accepted EBT transactions for SNAP or for food stamps. When we looked at transportation, that in the most vulnerable communities in San Diego, there was only 1 volunteer transportation program available. There were 4 active transportation vendors, but none of them had medical level transportation to help those who were homebound or disabled get to their appointments. And most of them required a minimum 2-day advance scheduling to book a visit, to book a trip. When we looked at housing, that 57% of households in San Diego were renting their homes, that most of those folks that were renting were spending almost 50% of their income on housing, which meant that they did not have the means by which to make home improvements. And so that's where you see lots of fall risk and all kinds of other issues related to the quality of the housing stock that these folks were living in. So that's one example of the systems level scan that we have to do to look at existing community-based organizations and their scale and capability to be able to ramp up and say provide, you may have a dozen lovely church ladies in a basement somewhere preparing meals for delivery, say 250 meals for delivery the next day. But now we need to get them up to providing 5,000 meals for delivery a day. That means we're going to need to build a commercial kitchen for them. We're going to need to hire all kinds of new helpers and sous chefs to help meet that level of production, that we're going to need to likely hire drivers and a fleet of vehicles and maintenance personnel to be able to do the deliveries. And this is all driven by the data that I mentioned earlier that gets us there. Next slide, please. Our framework for our investments usually works like this, where we will partner with an insurance company and we will establish a NewCo within their service area. This can sometimes be called a Center for Social Excellence. It can be called an innovation center. Some of our clients call it a social management services organization, but it's basically a platform that facilitates our investment and then contracting with the downstream community-based organizations and vendors that we know we will need to meet the need in the communities we're intervening with. We will then engage in data exchange with our client, the insurance company, and we will typically engage in a value-based arrangement with them so that we can, over the multi-year period of our investment, repay our investors by helping to share in the reduced costs that our interventions resulted in, and in some cases, the improved revenue that they saw, largely the results from better coding for risk adjustment and for improved star ratings or Apple ratings in Medicaid managed care. But this structure we've deployed many, many times now, and this works really well for facilitating investment and getting the accountable results from the downstream network of providers that we engage in. And this is really to our point of a new normal in how we think as insurers about network management. We typically think of network management as being doctors and hospitals and other providers of medical services, but now we need to get out of that mindset and to be thinking the new network management is going to include, food banks, shelters, affordable housing developers, and like-minded community-based organizations that will help us meet these needs sustainably over the long term. The next slide, please. And again, because we're investors and we have to answer to very rich people who want to know how their money is being used, we really then will launch and operate these interventions with an eye toward quantifiable results in 3 major tranches or stovepipes around member engagement, around the actual outcomes that we're achieving, and then the financial return that our client and our investors are getting from having stood up what ends up being critical infrastructure for our health insurance partner. So with that, that's the critical role of all of that data that's at health plans' fingertips. And again, once it's structured and made actionable, these are, the frameworks and the approaches for how you get quantifiable results from anti-poverty and anti-racism interventions. With that, we'll go to the next slide. I think, keep going. And I think that next one's just, here's my team. But anyway, Commissioner Borrain, back to you. I hope this was very helpful in thinking about how we deploy this stuff on the ground and the results that you can get from these types of interventions against poverty and racism. Thank you so much for having me. It was a pleasure.
Thank you for being here. I mean, I think that you guys have set all of our brains on fire, and thank you again to Michelle Everly for suggesting you guys because it's been a powerful presentation. We are stressed for time, and so I'm not going to ask questions, but what I am promising is a follow-up, because while I don't want to, have any carrier have to kind of give up its secret sauce, or, I recognize that, everybody's in this together. And so, we're all trying to find solutions, and there's room for everybody to participate. And not everybody's going to show everything all the time, because there is still a competitive environment, and that's a good thing. But we can still come together and talk about some core concepts. And I am very interested in your comments about product design and the MMLR. And I think that's a lot of fruit, a lot of stuff to talk about. And so I am thinking I may be driving my staff crazy. They're probably screaming behind now. But the idea of having some sort of a working group where, we can be a little bit more on the ground and maybe start to get a little bit more granular and technical about the things we can do in Baltimore neighborhoods and in neighborhoods in Southern Maryland or up in Western Maryland. What can we be doing? So thank you for your ideas. I appreciate that. What I'm going to do is I'm going to start us with the registered speakers. I'll call on everybody that we have as a registered speaker, and Ms. Morton, who's also had registered, but I guess didn't get the link. And then if there's anybody else that wants to speak, I'm going to ask people to keep their remarks to 5 minutes because we are running over. I'm here for the duration. I want to hear what everybody has to say. And with that, let me invite Michelle White, who is a resident in Baltimore County, to talk to us today about her perspective.
Commissioner, I'm not seeing Michelle White.
Oh, I'm sorry if we lost her, but okay. Well, let's see if she comes back. She can just let us know in the chat room. Is Dr. Herman here? Dr. Herman is a psychiatrist in private practice and a member of the Legislative Committee of the Maryland Psychiatric Society. Dr. Herman?
And also, I'm not seeing Dr. Herman.
Okay. I know that Dr. Kim Jones-Fearing is here. So she is also a psychiatrist in private practice, and she is a medical ambassador for the nonprofit Global Necessity and advocate for the homeless. And we have 5 minutes for you, Dr. Jones-Fearing. Very happy to hear from you today.
Hi, thanks. I really appreciated all of the speakers. You presented a wealth of information. I just want to get on to my some of my questions and a little bit of background. I am also a member of the American Psychiatric Association as well as the Maryland Psychiatric Association. And I had spoken to Dr. Herman, and I know that he wasn't going to be able to be present, but I said I would try to produce, try to give you some of his questions. But since I only have a minute or so, let's get going. I know that social determinants of health, racism, and poverty, basically, are affecting all of us, or most of us. And, I was born in the segregated South, and I don't expect that racism and poverty are going to go away just because we're having this talk about social determinants of health. I was always raised to believe that it doesn't matter where you come from, it's where you're going. And I have more than 20 years of education. Believe me, racism affects me on a daily basis, and sexism, not to mention ableism. I think that a lot of times when we talk about these things, we get caught up in, getting the data, things will be better as long as we get the data. Things will be better as long as people have a place to live. Things are going to get better as long as we're working to remove these inequities. And I'm here to say that there are things we can do right now today among the insurance companies and the government to end these disparities right now. It will cost you maybe $1. Remove that $1 copay for medications that are medically necessary. I have been working inpatient hospital in Eastern Shore, and with a locum tenens, which is basically temporary job. And many of the patients that we saw had comorbid alcohol, drug abuse. And when it came time to give them their medications for discharge, the vitamins that they needed to prevent brain damage from the alcoholism weren't covered. So those kinds of things are what damage our patients. And when I'm hearing about the social inequities and the poverty and the lack of food insecurities, this is bringing back up trauma for me, because I know that my patients, even in private practice, these are patients with private insurance sometimes, haven't been able to take the Depakote they've been on for 20 years because of not having access to food, which makes their stomach hurt. And at that time, there was no food pantries in our area of Howard County. So I'm sorry. I didn't know where the food pantries were. I'm sorry. That was my fault. So I believe that these carve-outs, and what Dr. Herman wanted me to talk about was the inability of us to get the medications that we prescribe into our patients because of algorithms that are biased and not scientifically based. For example, patients who might have bipolar 2 disorder, not doing well on Seroquel, which is the only medication that is evidence-based for bipolar 2 disorder, not doing well on it, can't tolerate it, try to give lorazepam, and they're not able to get it. And these denials of medication occur at the point of the pharmacy.
So the patient doesn't, so you're not dealing with the doctor. You as the doctor don't necessarily know that that's happening so that you can get
until days or weeks later when we get a call from the hospital that they're changing doctors because they need more structure or they need more social supports that you and your private practice can't provide. And these are the kinds of things these are the reasons we needed to listen to the patients. We need to listen to their doctors because their doctors and their family and the patients, they are the ones that know what's going on with their bodies. These algorithms are another word for racism because they're not always evidence-based. And believe me, algorithms are important. My mother was a science teacher and worked for 40 years in Dallas, Texas. I was raised in science. I was raised in STEM. And it has become impossible to reach my patients with my healing this last several years. So I just wanted to thank you at the Maryland Insurance Administration and Maryland Health Connection for giving this lecture because it, I did learn some things. I'm just hoping that I'll be able to better reach people who really need the help.
Well, thank you very much for participating today. I have written down the things that you've said, and I think your takeaways, there's several takeaways here that we can work with. And we can also be looking at when you've got better education and awareness, particularly for consumers, when the denial is at the pharmacy, to really have an understanding of, what tools, what kind of things can the consumer do when that happens, and the ability to contact their provider and look for an alternative or have the provider help them initiate an appeal from that denial. So definitely very, very important things that you've pointed out today that we can work from. So I appreciate your being here very much. And as a provider, that if you have circumstances where there have been denials or patients are confused about, what their rights are or what their coverage is, that you can always come to the MIA, and we have a team that does just that. So we're here for your patients all the time. So let me invite Mr. Frank Botenasak, who is representing an organization called Live Chair Health, which is working to improve African-American health outcomes by outreach through barbers and salons, which I think is phenomenal. So very, very happy to hear from you today.
Thank you for the opportunity to briefly address the group, or who's left. I hope there's still people listening in.
Actually, we still have a pretty good crew. Plus, we have a bunch of people on Facebook too. So
good. So the title for this particular webinar is very important to what we're doing. As you mentioned, Live Chair Health, which is a Maryland-based digital health venture, is working to reduce health disparities for people of color. We're focused on improving the detection and management of chronic health diseases like hypertension, cardiovascular disease, diabetes, because they are the root cause of so many of those health disparities. We connect people to recommended health plan covered healthcare providers and services, and we help prevent, manage, or treat those health conditions. And we do that by incorporating recommended healthcare services like health screenings, preventive care, and support for healthy behaviors into people's routine of getting a hair service in their own barbershop from their own barber or stylist. And this is a routine or habit that a lot of people have on a bi-weekly basis. It's something that happens 26 times a year. And I think that's really important. And I'm imagining that most people on this webinar are familiar with barbershop-based health screening programs. Dr. Stephen Thomas was going to talk about the program he manages at the University of Maryland. Celeste James at Kaiser mentioned that Kaiser's doing it. I think United Health was doing some community-based programs. They're all worthwhile. There is 40 years of evidence that this approach works. It has been proven to help raise the awareness, to actually help kind of surface health risks, and help make people aware that they really should be getting care for it. A lot of what you would have heard people talk about were grant-funded studies or, philanthropic supported pilot programs that after 40 years still haven't been kind of scaled up. And Live Chair Health recognizes that we really have to get the healthcare system, meaning the payers, Medicaid, Medicare, and the commercial health plans, to agree to pay for this. And that's what we're focused on. I mean, what we've seen ourselves and in research is that people without healthcare insurance are much less likely to get any recommended healthcare services because they're worried they're not going to be able to pay or afford their out-of-pocket costs for any healthcare, and they're really not connected to the healthcare system through a health plan. And that financial impediment only exacerbates some distrust that already exists by many minorities toward the traditional healthcare system. So we are basically kind of bringing healthcare services to people where they're already spending maybe every other Saturday. And we design programs that are really designed to benefit the barber or the stylist and the shop owner, the client, the healthcare professional who may be trying to help that patient, but only sees them once a year, or maybe doesn't see them at all, and the health plans. And we recognize that the health plans really, they're the ones footing the cost for healthcare. So really we have to make sure that first of all these people have health insurance. And I know that due to your efforts, we've been able to get the uninsured rate in Maryland down to about 6%, but among minority people, it's maybe double that. So in the barbershops, what happens is when someone comes in, we engage them, we get them to either do a health screening or talk about their health, and then we ask them to complete a health questionnaire, which is really an HRA. And among the questions, we're asking about their health risk and their family history and their social determinants of health. We also ask them if they have health insurance and who they have it with, and if they have and see on a regular basis their PCP. What we see is that most of the people in this population have health risks. They've got chronic health conditions. Sometimes they're known and managed. Many times they're known and unmanaged. In other cases, they're not known. It all starts with, our conversation really starts with, do you have health insurance? If not, can we help you figure out whether you might qualify for Medicaid or a subsidized ACA plan, which, as was mentioned earlier, due to the President Biden's generous expansion of the program for the next 2 years, they're better subsidies, and people can enroll at least through mid-August of this year. So we help people who are uninsured get insured. But just as importantly, because I heard this mentioned by Dr. Sidnor and Celeste James from Kaiser and other people, once you have health insurance, it's important that you actually are aware of the services, the recommended covered services that you get, and that you then take advantage of them. And it all starts with, are you seeing a primary care provider on a regular basis? And is that PCP really your quarterback for the right healthcare services at the right time in the right site of care? And that's what we're doing. We're identifying health risk. We're figuring out if they have insurance. If not, we try to help them get it through Healthcare Access Maryland. We then try to make sure that they have a PCP and that they are connected to the right covered healthcare services. And we're now working with health plans in the state of Maryland, including Medicaid MCOs. And we recognize for them, it's really about not only reducing health disparities among their insured minority members, but it's about improving health outcomes, improving the experience of care. And it's about better managing health utilization, because they prefer that person help get treatment for their pre-diabetes rather than develop full-blown diabetes. So we really think that because we're designing programs that work for everyone, especially the health plans that need to pay for this, that we think that this is what's needed to take this novel approach and make it available to everybody through every barbershop, salon, and maybe even churches. But we need to work with the Maryland Insurance Administration and all the health plans so that we can make sure that everybody is both insured when they get insurance, that they are ideally connected to a PCP, and they work with that PCP maybe the way they work with their own hair professional, and that they then use the recommended covered healthcare services so that we can keep them well and they don't end up with complications and end up in the ER or an inpatient admission. So thank you. That's I hope I covered it in less than my 5 minutes.
No, you're good. It's interesting. And there's an obvious point of connection with the exchange, right? So, if you're gathering this data to be able to coordinate with the exchange, which is, also, that guide and resource to what's the best plan, et cetera. But for those people that have insurance already, how do you currently have any interface with, whether it's an employer-based self-funded plan or an insured plan? What do you have? What's your interface there, if any?
So we're starting to work with some of the Medicaid MCOs, and they've made it very clear what they want their insured members to be doing, starting with make sure they have a PCP they see on a regular basis, make sure they get health screenings, make sure they re-enroll so they don't lose their insurance. We actually recently got into the 1501 Health Accelerator that's run by both LifeBridge Health and Care First. So we're beginning to tackle the commercial market with the guidance of Care First. We're looking to do business with all the Medicaid MCOs because really what's in the interest of the one big plan we're working with is in all their interest, and it's in your interest because you want people not only insured, but then utilizing recommended covered services and not ending up having a heart attack or a stroke because they have an unmanaged or even an undetected chronic disease.
Yeah, I mean, that's exciting. And I think as we, continue on this journey and look at these concrete things, one of the things that I definitely want us to do is talk to you about, as you are on the ground and in the field in these particular areas, how can we provide and produce better educational materials and resources for you to be able to give to people, and what does that look like?
Yes, and I want to give credit to Michelle Eberly, who we've met with multiple times, as well as Paris Barnes at Healthcare Access Maryland. What we said is we're going to find them. We're going to try to make sure that they take advantage of your resources to get them insured. They've been very supportive. So we're already working with that. We want to get all the, it's probably close to 10.
Once you're there, because I know the connector is awesome. And I know Michelle's talked about this and healthcare access, all terrific. For those people that have insurance that are still trying to navigate, what does this mean? And boy, when I hear no, what do I do? That's where the insurance administration comes into it. And I would love to connect with you and my folks because we're on this. I mean, we're very focused on new materials and new ways to Because what's loud and clear to us constantly when we're hearing from consumers is that so many people truly don't understand how their health care works and what
Very
kind
true.
of rights they have. And so we are on this mission to try to fix that and would love to engage with you.
I would love to follow up with you because we have their ear. We have an influential person guiding them. We want them to use their health insurance the way you want them to, in the right way, at the right time, in the right place.
Okay, that is awesome. And Joy,
Just one second, Commissioner.
Yeah.
So we have partnered with Dr. Thomas and actually gone to some barbershops and assisted people. And I would love if you would put your email and contact information in the chat, and maybe we can do something very similar with you.
Yeah, we're very familiar with Dr. Thomas. He does super. He was one of our early advisors. He's doing God's work. It's just we've got to move beyond grant-funded studies and get the healthcare system to pay for this. We need health plans saying it's in our interest. You'll save us money. You'll help deliver better outcomes. We can't do this with grants.
excellent. Thank you so much. And as I said, we will definitely follow up. And so let me now introduce or invite Dr. Abedi, who is with the Abedi, who is the president of the Maryland Association of Adult Day Services, to talk to us about this topic.
Thank you so much, Commissioner and Ms. Everly. And I have been just speechless listening to all of you guys. It's been an amazing, eye-opening experience for me. I'm a physicist by training, so I deal with technology in the world and other things, you know, in regular basis. But when I looked at the dimensionality of the problem, it just is very humbling. So I just wanted to thank you again for all of your all the members who have contributed to this field for years and years. I am relatively new to this field. My wife and I started a medical daycare in Gaithersburg, Maryland, about 2012, and it was, you know, by grace of God, it was just meant to be, apparently. And since then, I have kind of like, as a newcomer, I question why things are a certain way. So I kind of like, as opposed to getting used to why certain things don't work. So I think maybe I can contribute to one item today that could be potentially worth adding to the list of items and so on. Just for those who are not familiar with medical daycare, medical daycares have been around in the state of Maryland for over 40 years. It's a very well-established program. It has its own Kumar. It has Office of Healthcare Quality overseeing the basically compliance, and it's basically a certified entity, just like skilled nursing facilities and so on. And also, we also have Medicaid that primarily, I would say about 85% of participants in the program are being reimbursed through Medicaid at the present time. Some private pay and some VA and so on. But it's been always a question for me, why didn't Medicare cover the medical daycare? And why is it that there are no other insurance companies covering it? And it's been like, in back of my mind, I kept asking various different people, who should we talk to within the insurance community and so on. And I found out that it's a vast, vast entity. And, you know, to find the right individuals to connect the dots, it basically has been impossible for us to doing everything that we normally do and then try to do this. Until the head of HHS at Montgomery County sent me the email that you guys send out. And immediately I sent an invite, and then thanks to Craig, I was able to have a chance to bring this to you all's attention. I heard Landis talk about the food initiative, and Celeste and others have all mentioned things about various different aspects of social and racial and, you know, disparities and so on. I like to kind of like turn this a little bit around and talk about the group that I can't necessarily label them in a social or a racial category, but I like to call them the elderly and adults with disabilities. This particular group is currently being served through Medicaid, and we know that the number of elderly and individuals with disability is expected to grow. It's huge. It is expected to grow. These issues will not go away. And you know, when somebody goes to hospital, they get referred to their nursing, skilled nursing facility for rehab and so on. And then they get sent back to home. So imagine a case where a person has dementia or Alzheimer's and has the diabetes or some sort of a, you know, a high blood pressure scenario. If they don't know how to manage their medication on a regular basis, then they either take too much or too little or not at all of the medication. What does it do? It makes the problem bigger and larger, and it eventually might result in, let's say, a cardiac issue. Now, all of a sudden, the cost of this thing is orders of magnitude higher. The complexity of the problem is orders of magnitude higher. Whereas if we had managed it, it would have just been a matter of taking the right pill at the right time with the right amount. And that's what medical daycares come into this equation. It is not like you can have the person in the church's basement take care of their medical need. So the state of Maryland and also many other states have medical daycare facilities. It's well established. It is fully defined, and you can add to that. It's an existing facility infrastructure. You don't have to reinvent the wheel. You can actually include them in your equation right now today. There's 122 medical daycares across the state of Maryland, 19 in Montgomery County. They're serving about 6,000 individuals per day, rain, shine, snow, not just in November. They're providing all kinds of services to people. What are the services they provide? Transportation. They go bring them from home to the center. They actually provide social life to them in their language. Provide them with meals in a socially acceptable, in their cultural meals, so that they can actually eat. Nobody likes hospital food. They all hate it. And they said, in fact, we had a person come here on Sunday trying to come into our facility and say, if you provide meal, is it going to be authentic meal or is it a hospital food? They provide, I mean, I wanted to show you some of the slides, but unfortunately, there's not enough time. So meals, activities.
But please send them to us.
Okay, I will definitely do that. And I'll really appreciate if we can have an opportunity to have more individuals from medical daycare community present to the insurance community how you can actually eat, have your cake and eat it too. I've been told by many different groups that we want to improve quality of health, but we want to reduce costs. Well, that's exactly what medical daycare does in the following fashion. People who are going to medical daycare, they're being monitored on daily basis. Their vitals, they're coming into a beautiful, lovely, family-oriented environment. And then we know them. If they are a little bit offbeat, we can tell. It's basically not like you can see it in your computer, in your business analytics tool. It's a human being. And eventually, when it comes to operations, you need hands and feet on the ground. And you already have that in the state of Maryland on the ground, but you're not covering it. And please, for all the insurance companies, CEOs, and so on, add medical daycare to your list of items to find out a little bit more about. And ask the question, why aren't we covering this? Because this is going to save you money. If you want information, we have tons of data on information. There's no question about it. I mean, we have no problem with that. Improve quality of life, reduce. There is a phase in everyone's life that they're independent and they don't need healthcare. I mean, pretty much they're independent. There is a phase in somebody's life that they're fully dependent, and that's nursing homes and hospice and so on. These two areas we got covered. But when it comes to the in-between period where you're partially dependent, we don't have coverage. That's the worst part, because if we can manage the partially dependent phase, it's just like a vehicle that you actually change the oil and change the brake system, it will continue working for much longer, better quality. If we can help maintain the individual's health throughout that partially dependent phase, which either it can go with their ADLs or it can go based on whether they have cognitive issues and so on. And I'll stop in just about 30 seconds. If we can manage that, then we'll be able to have all the savings and provide better quality of care for individuals. Why is it that Medicaid is covering this? And Seema Verma in the previous administration was instrumental in getting medical daycare in the list of services covered through Medicare Advantage. And I have been trying to find out, why don't we cover that in Medicare Advantage? What are the insurance companies that provide Medicare Advantage at least we can expand to Medicare Advantage. But I really think hospitals should actually pay out of pocket. When somebody comes over there, they're actually leaving the hospital. You want to minimize revisits to hospitals? Don't just send them home where the problem was. Introduce them to medical daycare. Let them be brought to the daycare on a daily basis or 3 days a week or something. We watch them. We have nurses. We have activity coordinators. We have people of their own language talking to them. They can actually, and then you're stuck in the middle of in your room looking at the walls. You end up with depression, and depression will slow you down. You eat too much and so on. You end up with all kinds of additional medical problems. And this COVID period showed us medical daycares actually delivered food to people throughout this past pandemic era, even though they weren't required to do so. We took care of 6,000 people in Maryland, but I think we should be able to take care of more people because the infrastructure is there, process is established. It's not like creating something, from scratch. All the entities are there. One thing I've found is medical daycares are not invited to table when there is skilled nursing facilities and hospitals there. I think that's an oversight. We are part of continuum of care. The department depends on us. So when you're inviting hospitals and nursing homes to any meeting, I suggest add medical daycare in there because that expertise and that feedback will only help you come up with better solutions. I appreciate everybody's time. God bless you guys. It's been fantastic.
Well, thank you very much. Very, very informative. I have lots of thoughts having been on the University of Maryland Systems Board and thinking about that gap and, readmissions and what that means. So please send me your slides. I think Craig can provide his email. I know that you registered to speak. So if we can get your slides, I would appreciate that. I'd like to see them personally, and we will post them.
Thank you so much.
You're very welcome. And last but not least, that of people that have indicated so far that they want to talk is Ms. Morton. So we would invite you, Ms. Morton, to speak today. Very happy to hear from you. Thanks for hanging in.
Thank you. Thank you. Thank you for allowing me to speak. I felt this whole presentation was very nice and informative. I've learned a great deal. I am founder of Faith Over Fear Economic Empowerment, Inc. I live on the Eastern Shore. I'm trying to help minority business owners become more visible in our community and create sustainability. I also help people do taxes as well. And what I've been finding, the 1095-A, that's the form that you get when you purchase the insurance through the marketplace. And when people apply for the insurance, in this particular case, this person didn't have a job, so he was offered the insurance. So he had the insurance for like 4 to 5 months with Blue Cross Blue Shield. He said he was paying like $20 a month. But when he went to file the taxes, he had took a job, and when he went to file the taxes, he made over the amount. So he has to pay like $7,500 back. So with this being said, it's almost like if you get the insurance, you probably shouldn't take a job, or you are forced to take a lower paying job so you won't have to pay this health insurance back. So he stated if he knew that he was going to have to owe this much money, that he probably wouldn't have taken a job. So there you have people not, looking for jobs because they have the insurance because of the fear of paying it back. So I don't know if this is being addressed, or if you apply for it, can you just not be penalized by getting income over that amount when you go to file?
So not my area of expertise. I know that there have been conversations. What I can do is make sure that we take your contact information and figure out who can answer your question and connect you with that person. But what you're describing, which is a circumstance where someone qualifies because of what their income was, and then by the end of the year they have exceeded those amounts. And what does that mean in terms of having to pay something back when they were legitimately at a certain income level at the time that they sought the subsidy or got the tax credit, and then having to Yeah, so I don't know the answer to that question.
Commissioner
But-
Brain, this is
Yeah,
Michelle.
oh, please, yes.
So we are happy at the exchange to really help look at this particular situation. If there is a change in income, we do always inform consumers that if they have a change in income, they need to report that change of income to us because it could change their situation. But again, we can look at this particular instance and see if there's anything we can do to help this individual.
Thank you. And I had one other question. When you all said that you want to lower the plan, lower the prices in the marketplace, I guess make it more affordable for people to purchase the insurance. So who's going to pick up the cost? Is that going to be lowered across the board, for employees who actually have jobs? Is the health insurance going to go down?
So the
No,
way
yeah, go ahead. I'm sorry.
So I'll take the part that has to do with the insurance rates, and then Michelle can address the part that deals with subsidies, which the exchange administers. So the actual cost of insurance, the rates of insurance, which have been going down because we have put aside money that's been collected from various sources into what's called a reinsurance pool. So when insurance companies have to pay claims of a certain amount, they can get reimbursed from some of that. That's not, so that comes from an assessment that's been spread out among carriers and then some other sources. So that, along with other initiatives, has consistently lowered the cost of that monthly premium for insurance, whether it's coming from an individual policy or it's coming from an employer, a policy that the employer bought. There are other types of insurance that come through employment that are not really coming from an insurance company, but the employer is self-funding that plan. And we don't have any control over that. So the majority of people who have health coverage through employment are in self-funded plans. And that is not something that we regulate. What my shop does is they look at all the numbers and they tell companies what rates they can charge. Then once we set those rates, then Michelle's folks kick in, because you can go to, if you buy on the exchange, and then Michelle, I'll kick it over to you.
Great. And so that's where the tax credits come in. Based on your income, you are eligible for different levels of tax credits. And that is only available in the individual market. So if you think of it such as if you have employer-sponsored coverage, usually your employer is picking up a substantial portion of your health insurance for you. That's a benefit you get as part of your employment. For people that don't have employer-sponsored coverage, there is no employer helping to subsidize that. So that's where the tax credits come in. And it operates very similar to like a child tax credit or any of the other tax credits that the federal government has. The only difference is that it's payable up front every month, and it's paid to the insurance carrier to reduce that cost of the premium. And those are the ones that we've talked about a couple times in this session, where President Biden has increased that tax credit amount, made it much more generous. So we're seeing the cost of health insurance through the individual market come down significantly.
But you are correct, Ms. Morton, that we do need to look at the small group market as well. There is an element, there's a program for small group, but it's not as robust, shall we say, and there aren't as many employers that really qualify for it. But that's certainly an area where improvement can be had when you're talking about people that are employers that are buying coverage and people that are getting their coverage through their employer's plan. So there's work still to be done there. But on the individual side, there is just an enormous amount of work, that really good work that's been done.
Okay. All right. Thank you for the opportunity.
You are very welcome. So we are at 4:33, and I just wanted to see if there was anybody else. I don't know if Craig, anyone else has asked to speak, or?
I'm not seeing anyone else, Commissioner.
Okay. Well, and our attendance is beginning to dwindle as we lose people. This recording will be accessible on our website. So please absolutely, access that. If you have follow-up questions or comments that you want to make, Craig provided his email address and we'll be happy to receive them. And we'll definitely be doing a follow-up with several of these ideas. I will also let you know that we are about to schedule our third session. You want to take just a second, if you're still on, Joy, and give a short description of what our third listening session is going to be about?
Yes, thank you, Commissioner. Our third session, which will take place the last week of June, will be focused on financial security issues for the LGBTQ individuals. And we're going to be looking at some of the life insurance and disability products. So that will be the focus of that discussion, and announcements will go out concerning that probably next week.
Excellent. Thank you so much, Joy. And thanks everybody for their participation and for those of you that were able to hang in to the end. And with that, we will close down for today. And we'll look forward to seeing people at all of our sessions, including our next listening session. And a very special thanks for the Maryland Department of Health. And I know that we didn't get a chance to speak to him, but Dr. Brathwaite was able to come in. And thanks as always, Michelle, for coming, for your good work. And thanks to Dr. Martin as well. So take care, everybody, and talk soon.